We are live, ma'am. Please start.
Namaskar and good evening, everyone. I welcome you all on the second day of Paradigm Shift in the Management of Common Cancers. And with immense pleasure, I would like to invite Dr. Piyush Mehta, who is consultant medical oncology at Suhana Hospital, Mohali, for the welcome and introductory note and to take the proceeding further. Over
Okay.
to you, sir.
Thank you and good evening, everyone. Today is our day two of paradigm shift in the major cancers. And as per the ESMO 2023, most of the topics we have included from guidelines or the changes which have happened in ESMO in 2023. So, with me now, I have Dr. Suhas. Sir is a medical oncologist at uh, Rohtak, and sir is a senior of mine. So, over to you, Dr. Suhas.
Thank you, Dr. Piyush. So today the topic which has been allotted to me is the role of PARP inhibitors in today's era in prostate cancer. So it's a very important topic to talk about, as there has been a lot happening in the PARP inhibitors and in the diagnosis, in the management of, especially in the management of metastatic castration-resistant prostate cancer. So let's start without any ado. So new age management of prostate cancer, a focus on PARP inhibitors. So to talk about epidemiology of prostate cancer ranks about 12th in incidence in India, with a reported incidence of 34,540 cases, which causes approximately 16,783 deaths as per Globacon 2020. And almost all the patients with metastatic prostate cancer go on to develop a castration-resistant prostate cancer, which is a very well-known phenomena. Overall prognosis of metastatic CRPC remains poor, and survival of approximately 1 to 2 years. Now, to talk about the risk of developing prostate cancer, as we all know, it increases with the age. However, incidence is increasing in young men. Prostate cancer is most frequently diagnosed in men between the age of 65 to 74, with the median age being 66. 1 in 9 and 1 in 14 males may develop prostate cancer in their lifetime. As per the data, worldwide incidence continues to increase in young men, where we can very well see that how the prostate cancer is now coming up in younger age groups. So prostate cancer is not a single entity. It is actually comprised of multiple disease states, which consist of a localized disease, a non-metastatic, a hormone-sensitive metastatic prostate cancer, and a metastatic castration-resistant prostate cancer. So localized disease can further be divided into a newly diagnosed, which is newly diagnosed localized disease, newly diagnosed locally advanced disease, and or a localized disease with a rising PSA. So which is actually the biochemical failure after local therapy, or a non-metastatic castration-resistant prostate cancer, which is identified by rising PSA, and there is a biochemical failure after hormonal therapy. Hormone-sensitive metastatic prostate cancer is maybe a newly diagnosed disease, where the newly diagnosis of metastatic disease is made in absence of any kind of ADT therapy. And metastatic castration-resistant prostate cancer, it can be asymptomatic or minimally symptomatic, which needs to be treated or not treated on the basis of the symptoms. It may be symptomatic and a disease which has progressed on or after the first line of chemotherapy. So metastatic prostate cancer is biologically heterogeneous. Approximately 90% of the metastatic CRPC have a genomically aberrant pathway involving androgen receptors, PI3K, DDR or WNT, and cell cycle related signaling. So our topic of today, or our interest, is basically the DNA repair genes, which constitute approximately 23% of the mutations which are identified in DNA repair pathway. So mutations in DNA repair pathway can lead to genetic instability and drive tumor growth. So as we can see, the main pathway involved in repair is the base excision repair pathway and the nucleotide excision repair pathway. But the DNA double strand breaks are to be encountered by the non-homologous end joining or HRR genes, which include ATM, BRCA1, BRCA2, PALB2, or CHEK1, 2, or RAD51. HRR is the key mechanism of repair of DNA double strand breaks. Now, how is that important in the case of? Let's come to that. So this was a study which was conducted and where approximately 400 plus samples of the biopsy were analyzed for what kind of genetic abnormalities they are carrying, especially in terms of DNA damage response genes. But of that, approximately 27% had some kind of genetic abnormality, and of which BRCA2 was the most frequently found. And NCCN guidelines acknowledges how the prostate cancer is heterogeneous and thus highlights the need to consider to check for mutation of HRR or MSI and checking of deficient MMR even for regional and metastatic prostate cancer. So as per the NCCN guidelines, we have various risk groups, which include very low, low, favorable, intermediate, unfavorable, intermediate. But as we can see, NCCN guidelines have recommended utilization of germline testing in almost all except for in very low. Whereas molecular testing is not usually recommended except in patients who have a regional or a metastatic high risk disease. So as per the ESMO and EAU guidelines, these recommendations are not yet incorporated, but the Philadelphia Consensus Conference supported the consideration of BRCA2 testing at least in screening, management, and informing the prognosis and treatment. So background and rationale, now we talk about the same. Despite significant progress in systemic therapy, metastatic castration-resistant prostate cancer continues to be lethal. Metastatic CRPC is molecularly heterogeneous. Up to 30% of mCRPC harbors deleterious alterations in DNA repair genes, including those with direct or indirect roles in homologous recombination repair. These genetic alterations can confer sensitivity to PARP inhibition, of which BRCA1, BRCA activity has been reported with PARP inhibitors olaparib in patients with prostate cancer harboring HRR alterations. So this was the first PROFOUND trial, which actually randomized to look for the efficacy and safety of olaparib versus new hormonal agents in patients with HRR mutation who have a metastatic castration-resistant prostate cancer. So eligibility criteria were included only required failure of the prior treatment with a new hormonal agent for metastatic prostate cancer, which may include any hormone-sensitive or a castration-resistant prostate cancer. So this was analyzed by a central review, and there were two cohorts which were made. One where only BRCA1, BRCA2 were tested, and another the whole of the HRR panel was tested. This testing was done with the Foundation 1. And this was further divided into a 2:1 ratio, and patients received olaparib in one arm and the physician's choice in another arm. So, and everything was actually centrally reviewed. In PROFOUND trial, as we can see, the cohort A had only 3 genes, which are the major 3 genes. The cohort B consisted of the 15 genes, which were covered in the Foundation 1 comprehensive cancer panel of cancer-related genes. Genes were selected based on the mechanistic role of HRR clinical efficacy data, hereditary cancer risk, preclinical evidence of the sensitivity of PARP inhibition, prevalence across the solid tumor types. BRCA1, BRCA2, and ATM are the best characterized and or frequently are mutated HRR genes in prostate cancer and hence were included in cohort A, whereas the genes in cohort B may be considered as exploratory. So baseline characteristics were almost similar in both the cohorts as well in both the arms. So metastatic disease was burden, as we can see, was much higher, especially in patients who received a physician choice treatment. And ATM gene was found to be higher in patients receiving olaparib. So now coming on to the other things. So baseline PSA was also higher in patients receiving physician choice. So somehow the physicians were not convinced in giving olaparib in the patients with a high PSA or the patients who had more of visceral metastasis. And also the patients who had a poorer performance status were recommended more for olaparib. So if we talk about the genetic aberrations, as we can see, the genetic aberration of BRCA2 was most frequently encountered, followed by ATM. And another thing which we can observe here is that CHEK CDK12 was also found very frequently. So, but the PROFOUND trial met its primary endpoint. Liprenza significantly improved the radiological PFS by BEICR, that is the central review, in patients with alteration in BRCA1, BRCA2 or ATM versus physician choice. Olaparib reduced the risk of progression or death by 66% versus physician choice. In cohort A, the median rPFS was 7.39 versus 3.55, and the median difference, if we talk about the delta in months, was 3.84, and hazard ratios were to the tune of 0.34. As already mentioned, around 66% difference, which was statistically significant, and the graphs are also very much in concurrence with the same. They are separating very much initially and have maintained that separation for a very long period. As we can see that most of the subgroups benefited with the addition of olaparib rather than from the physician's choice. And but the PROFOUND trial was not powered to demonstrate the difference between the subgroups. Significantly more patients with alteration in BRCA1, BRCA2 or ATM had an objective response whilst on olaparib versus physician's choice. As we can see, 1/3 of the patient in olaparib arm achieved an objective response, a 21-fold increase in odds ratio of olaparib compared with physician's choice. And at an interim analysis, olaparib had a favorable trend in towards OS also, and patients with alteration in BRCA1, BRCA2 or ATM gene, despite more than 80% crossover for eligible patients. So any patient who was actually initially started on olaparib was found to be much more benefited. So statistically significant and clinically meaningful improvement was seen for centrally reviewed radiological PFS in olaparib versus physician choice treatment. And as we can see, the radiological PFS was huge. Median radiological PFS was significantly better with addition of olaparib. So it approximately reduced the risk of progression or death by 51%. Patients with qualifying HRR mutation experienced a significant improvement in median rPFS of approximately delta of 2.3 months. And again, if we can see, if we talk about the overall population, subgroups have benefited except for those at ECOG performance status of 2. Though the hazard ratio is still better, maybe because the numbers were too low to provide any relevant data or relevant conclusion for the same. So significantly more patients with qualifying alteration in the intention to treat population of cohort A and B had an objective response to olaparib versus physician's choice, and the odds ratio was again to the tune of approximately 6. At interim analysis, olaparib showed again a favorable trend even in OS in both when cohort A and B were combined, despite of more than 80% of crossover, and hazard ratios were 0.67. The data is still not mature, so the p-values are still not available. There is evidence of clinical activity of olaparib in patients with alteration in genes other than BRCA. 97% patients randomized based on the alteration in 8 of the 15 single genes. 7 of 15 genes had alteration frequency too low for a descriptive statistics, as we can clearly see in this chart. So median duration of treatment with olaparib in cohort A and B was almost double that of the physician's choice, and approximately 1/5 of the patient are still receiving the drug in the olaparib arm at the cutoff versus approximately 1/10 of the patients in physician's choice arm. So median treatment duration with olaparib was 7.4 months versus 3.9 months, which again is a huge difference. And if we talk about the side effects, obviously patients receiving olaparib had a bit of higher number of side effects, but that was not very much significant. Dose reductions, if we want to see, those reductions were significantly higher with olaparib, and discontinuations were also significantly higher with olaparib. Patients received olaparib for nearly twice as long as control arm, which may have contributed to the higher rates of grade 3 or more adverse events or adverse events leading to discontinuation in the olaparib arm. The adverse event profile of olaparib was generally consistent with known safety safety profile, and there were no new side effects which were found. The most common adverse events, as we all know, included anemia, nausea, and fatigue. 4.3% of the patients on olaparib experienced pulmonary embolism versus 0.8% with physician's choice. There were no reports of MDS or AML as they have been encountered in the previous studies from breast cancer. So adverse events of special interest. If we talk about hematological toxicity, it is a recognized complication of olaparib. In PROFOUND, approximately 21.5% of the patients treated with olaparib experienced grade 3 or more of anemia. 3.9% had more of grade 3 or more of neutropenia, and more than grade 3 or grade 3 thrombocytopenia was experienced in approximately 3.5%. MDS, the overall incidence of MDS or AML in patients on clinical trial with olaparib monotherapy for long-term survival was less than 1.5%. In PROFOUND, with current follow-up, no patient has yet developed MDS or AML. Pneumonitis, which included events with fatal outcome, has been reported in less than 1% of the patients treated with olaparib. In PROFOUND, pneumonitis was reported in 4 patients treated with olaparib who had resolved at data cutoff for their analysis versus 2 in the control arm did not resolve. So the majority of the samples assessed in the study were from archival biopsies derived from the primary tumor. So,
sir, kindly conclude your talk in 2 minutes, please.
Sure. And to talk about what data we have taken up from the PROFOUND, HRR prevalence in screened population, qualifying HRR alteration was observed in approximately 28% of the patients, and CDK12 has been found to be a newer kid on the block and was contributed approximately 6%. BRCA2 has been found to be the highest. Among remaining 11 genes in cohort B, only contributed approximately 6%. So test failure is a possibility. Why does this happen is important. Pathology failure, no adequate tumor content, DNA extraction failure, insufficient DNA yield, and failure after DNA extraction. DNA quality is not adequate for NGS testing. So if we can talk about it later on, how to do this. And for NCCN recommendations for risk groups, regional, NET, N1, M0, germline testing is recommended. Molecular biochemical testing may be recommended. For metastatic, both of them are recommended. So now we talk about any case with metastatic or non-metastatic. Now another drug has been added to our armamentarium. That is, we can use olaparib for the further treatment. So Gozerlin as an adjuvant therapy in high-risk localized locally advanced prostate cancer. So Zoladex has been used. We can skip this. So in totality, I like to conclude over here that olaparib is obviously a drug which has helped us in improving the prognosis of patients with metastatic CRPC, especially those who have been found to have some kind of mutation in their homologous recombination genes. So I think I've made my things bit clear, and hope that this talk may be helpful and will help us to understand better how HRR genes may be useful and can be utilized further in treatment of metastatic castration-resistant prostate cancer patients, and will help us to prolong the survival. Thank you. Thank you, Dr. Piyush and the team, for inviting me.
Thank you, Dr. Suhas. Thank you for this excellent presentation and a very detailed presentation. If anyone has any question, they can put it in a chat box and we can take it together after this prostate session. Dr. Jagdeep sir will also discuss regarding the prostate cancer, so we can take it together.
Thank you, Piyush. Shall I start my presentation?
Yeah, yes. Good evening, sir. Good evening, sir, and welcome, sir, and thank you.
Thank you, Piyush. Thank you, Team Horizon, for managing this session. So, my assigned topic is on the prostate cancer. Hope my screen is visible to you.
Yes, sir.
Yes, sir.
So, is it now is presentation mode? So, is it
Yes, sir.
moving? Is it moving?
Yes, sir. Slides are moving.
Thank you.
Yes,
Thank you
sir,
so much.
it's moving, sir.
Thank you. Thank you once again for giving me this opportunity to deliver a talk on this management of the metastatic hormone sensitive prostate cancer. So some of the things already discussed by Dr. Suhas regarding the molecular testing for the patient in the metastatic cancer. So I'll be taking more on the hormone sensitive metastatic prostate cancer. So why is it important to discuss about the patients with the prostate having this metastasis and hormone sensitive? Because around 15% of the patient, they have a metastasis at time of diagnosis, and among those, around 40% of these patients they die of this in the patient who are presenting with a primary hormone sensitive. So these patients generally respond to ADT and in around 90% of cases, but still they progress to CRPC close to after 2 to 3 years of progression. So this is a diagram showing how we move from localized to non-metastatic CRPC, hormone sensitive prostate cancer, and metastatic CRPC. So today I'll be discussing hormone sensitive metastatic prostate cancer. So the definition of this hormone sensitive metastatic prostate cancer, it is that still responds to ADT, and it is not necessarily that ADT is naive. The patient could have been exposed in the previous part as a ADT as a part of primary therapy, and as NCCN uses this castration naive even when a patient have a neoadjuvant or concurrent or adjuvant ADT as a part of radiation therapy, provided that they have been recovered the testicular function. That's very important. If the patient doesn't have the recovery of the testicular function, then we cannot label as such. So how we make the treatment decision in the patient who present with us? So there are a lot of factors. It could be disease factors in the form of the extent of disease, distribution of metastasis, symptomatic versus non-symptomatic, and other features like histology of the disease and rate of change of burden disease. And the mainly other things, treatment resistance could be primary acquired, or the other treatment on the patient factors can be like it's a first line therapy, patient fitness, other comorbidities. So these all taken together totality, they make a lot of impact when we are deciding a treatment for a patients. And there are very limited prospective sequencing and head-to-head studies to guide a treatment choice. So it means if one uses any of the lines and other person uses, we cannot guide that this is better and that is not a good one. ADT remains a mainstay of treatment among the patients in all systemic therapy in the metastatic hormone sensitivity, and it could be formed in the along with the chemotherapy. It could be in the form of the oral drugs, and newer generations anti-androgenics could be there, enzalutamide, or can be combined with the RT when we are giving to the patients in the metastatic setting. So this is one of the Cochrane-based data which shows whether we are giving early or late ADT, what's the benefit. Of course, when we give this ADT in the early or the onset, we have a better outcome in the patients, and this favors the patient who receive early ADT have a better outcome. So ADT can be either surgical or medical, not going to detail in this. This is a very basic of these. So this is ADT for the metastatic cancers, can be ADT alone, can be the orchidectomy or the agonist or the antagonist or the LHRH, can be along with the combination of the chemotherapy or other drugs, enzalutamide, abiraterone, apalutamide, or darolutamide. So this one slide is showing whether we go with the agonist or we go with the antagonist for the prostate cancer, and it has been demonstrated in a phase 3 trial. The Degarlex, when compared with the leuprolide, the patient who are indicated for the ADT, they are approximately similar outcomes, and some of the adverse events related with the leuprolide are less as compared to Degarlex. Otherwise, the patient who receive either Degarlex or leuprolide, they have the same testosterone levels of the castration. So another drug into our basket is the relugolix, and of course I have not used this, and I am not aware whether somebody has used or not. So this is again proved in a phase 3 trial, which has shown that relugolix is 120 milligram oral given versus leuprolide. It has shown a better result. Basically, it was the trial to prove the non-inferiority, but when it has crossed that limits, it shown that it was superior to the leuprolide. So you see the castration rate, sustained castration rate with the leuprolide or relugolix is approximately, seems to be initially, it seems to be that it's non-inferior, but it proved it was superior. That is 96.7% with the relugolix versus 80.8% with the leuprolide. So similarly, the important thing to tell that patient who receive this antagonist, they achieve earlier this castration levels as compared to the patient who are getting this agonist. So patient who are this on Degarlex or relugolix, they are achieve a better earlier rate of testosterone fall. And approximately in this oral therapy, approximately 3 to 4 days, the castration is, you can see that more than 50% decline in the castration, the testosterone level is seen. And the PSA decline is almost evident at the 14th day when you are starting this therapy, and approximately more than 50% patient have this fall in serum PSA levels. So another important thing when we are treating with the metastatic settings, whether it's a high volume or it's a low volume, that's very important. And high volume is defined that it's more by 4 or more than equal to 4 bony metastasis and or visceral metastasis. And if it's a bony metastasis, 1 or more than has to be beyond the pelvis or the vertebral column. And the volume of disease has a significant therapy-related implication when we're treating a patient with those. So considering all these in the treatment of the metastatic hormone-sensitive prostate cancer, so the treatment backbone is the ADT alone, or it can be given in combination with either docetaxel, abiraterone, enzalutamide, apalutamide, or the triplet combination in which you can combine docetaxel along with the abiraterone in the ADT. That could be one in the high burden disease, but not in the metastatic setting. So of course, the risk and volume of the disease, that's again important factors deciding the therapy for the patients. Low volume can be either abiraterone, or high volume can be either docetaxel or abiraterone, combination of both these. So this is just I told that why we are considering these drugs, because you have to take a lot of things when you are planning a treatment, and the practical considerations are the most important, the patient performance status and patient comorbidity like cardiovascular disease or bone disease. Then you have to think other adverse event profiles and the duration of the therapy and administration. And of course, in our setup, financial toxicity is most important. Giving a agonist once in 3 months versus antagonist once in every month, that is again a major challenge for us. And there is no data for sequencing, which you give either abiraterone before or after docetaxel, or you use other drugs like enzalutamide before or after. So there is no very clear-cut data for that. So these are, this slide shows that these are the major important trials which has been done in the metastatic setting, the hormone sensitive, and JETEC, Chartered, Stampede, and these were all in this subset. You see in all these, the docetaxel along with the ADT versus the ADT alone. So other was the combination of the ADT along with the abiraterone or enzalutamide or apalutamide or darolutamide. So these different phase 3 trials, they showed which combination do better as compared to the comparative arm. So again, this is a slide of the same trials. They're showing which are the comparative arm which have been used, and the disease risk, majority are the high risk or the high volume disease. And people, means the patients who receive this therapy, they do better when they have a combination of ADT with the chemotherapy or with of the abiraterone and enzalutamide as compared to the ADT alone. So now just giving a brief of this, like in CHAARTED, this is again a phase 3 randomized trial with the ADT plus docetaxel versus ADT alone. And you can see patient who received this combination, the median OS was 57.6 months versus 44 months in the patient who was receiving ADT alone. Similarly, in the STAMPEDE, which was a multi-arm trial, in this, I think arm C and D, they were receiving the patient with the docetaxel along with the standard of care, that is the ADT. And again, the patient who received this ADT along with the docetaxel, they tend to do pretty better as compared to the ADT. Overall survival, the patient who received the ADT along with the docetaxel, they have a better median overall survival as compared to the ODT alone, that is 56.6 months versus 44 months. So another important thing when you are comparing these drugs along with the combination. So the patient who have a high volume disease, in those, the combination of this docetaxel along with the ADT has a better outcome as compared to the patient who are having a low volume disease. So if you see in the B graph, the patients who received this ADT and the docetaxel, the median OS was 49.2 months versus 32.2 months in the patient who were receiving ADT alone. But with a low volume, they're almost doing the similar. So there is not much a significant difference in the patient with a low volume disease. So that could be managed with a single ADT. So this is more deciding in the high volume disease. Again, in this CHAARTED trial, after a median follow-up of 53.7 months, the patient, you see that with the high volume disease, they tend to do pretty better as compared to the low volume disease. You know, this was a meta-analysis which confirmed that the combination of this docetaxel to ADT, they improved the overall survival of the patient with a metastatic hormone-sensitive prostate cancer as compared to the standard of care, that is the ADT alone. In this JATEC trial, initially there was no such benefit, but this meta-analysis consistently showed that these patients tend to do a better. Similarly, the other trials, that Latitude, in which the ADT was combined along with the abiraterone in the metastatic castration-sensitive patients, and in these patients were again divided into the high risk, at least among in which they should have at least 2 of the following features, that is either Gleason score more than or equal to 8 with a measurable visual metastasis or more than or equal to 3 bony lesions. In the STAMPEDE, that was a trial which was started a long back, and they had multiple arms. Again, in this one of the arms that was showing the combination of ADT along with the abiraterone. And these patients, again, who were newly diagnosed metastatic, that was a pelvic node positive or high risk as like defined by the more than 2 high risk features. That is a Gleason score more than 8 or PSA more than equal to 40. So in this, if you see the patient who received the combination of ADT along with the abiraterone, they tend to do a better as compared to the patient who receive a single agent ADT in the Latitude. But in case of STAMPEDE, that was also showing some difference with a hazard ratio of 0.6. That was also again statistically significant. So both these trials consistently showed that the combination of the ADT along with the abiraterone, they tend to do a better as compared to the comparative arm, that is the standard of care ADT alone. So the final parameter analysis of this Latitude trial, if you see the patient who received the combination of this ADT along with abiraterone in the interim, in the second as well as the final analysis, they tend to do pretty better as compared to the patient who were receiving single agent ADT. So again, similar patient who were having a high volume disease, they tend to do better as compared to the patient with a low volume disease. Though that is not, means it does not make that you should not combine abiraterone with the ADT, but the patient with the high volume disease, the median overall survival was close to 49 months versus 30.3 months patient who were receiving standard of care ADT. This STAMPEDE also showed that the patient who received this abiraterone along with the ADT, they have a better failure-free survival as well as the overall survival of the patient with the metastatic hormone-sensitive prostate cancer. So in short, these all drugs along with the either docetaxel or abiraterone, they tend to do a better in the patient who receiving this combination with the ADT as compared to the standard of care. Next come the important drugs, that's the third generation entry androgens, that is apalutamide, enzalutamide, and darolutamide. And when it has been seen in different trials, which I'll be just elaborating, they also tend to have better overall survival compared to the ADT. So this Titan study, basically in this, which a patient was randomized to ADT plus apalutamide, and comparative arm was as standard of care ADT. And the primary endpoint was the radiological PFS, and the secondary endpoint was the overall survival. And it has been seen that patient who received this apalutamide along with the ADT, the radiographic PFS was significantly better as compared to the patient who were receiving this ADT. So in this, it was not estimated in the patient who are receiving this apalutamide as compared to 22.1 months in the patient who were receiving standard of care ADT. And if you see on the B graph, all the subsets, that is a patient of any performance status, any geographic region, with or without bone metastasis, visceral metastasis, and having any Gleason score more than or less than 7, other features of like baseline LDH level and disease volume. So it has been shown consistently in this forest plot that combination of this ADT along with apalutamide, they tend to do better as compared to the standard of care ADT. So this overall survival, again, it is showing that though there were in both side placebo as well as in the apalutamide, it was not estimated, but this graph showed that patient who receive this apalutamide, they tend to do better as compared to the patient who are receiving standard of care ADT. So continuing with the same, the PFS, if you see at 2 years, the patient who receiving this apalutamide and this versus combination of ADT versus ADT, they tend to do better in the combination arm as compared to the standard of care ADT. And overall survival was not reached in both sides, means median was not reached in both sides.
Sorry to interrupt, sir. Kindly conclude your talk in 2 minutes.
Okay, I will not go details. This is another study of ARCHES which compared with the enzalutamide along with the ADT versus ADT. Again, it showed a better outcome with the patient who receiving the enzalutamide in combination with the ADT. So this study piece 1, this is another 2x2 randomization study, again, which is standard of care ADT plus abiraterone next arm. Another was a standard of care ADT plus radiotherapy. And fourth arm is ADT plus abiraterone plus radiotherapy. So this randomized was done to check for the outcomes. And the overall, it was basically patient who have already received 1 line of chemotherapy or ADT. In this I just evaluated that these are the different arms in these subgroups. And it has been seen that patients who are receiving that abiraterone along with a docetaxel, with or without RT, they tend to do better as compared to the standard of care. So in short, to conclude that whether we combine ADT with the abiraterone, enzalutamide, or apalutamide, these people tend to do better as compared to the single agent ADT. So not going to detail in this. So these are the different toxicities seen with the drugs, the abiraterone, and most importantly, hypertension and the increase in the sugar levels. So the result of this, that if ADT alone, you can see the different trials which are supported that 33 months with the charted, again, JATAC or STAMPEDE. So this is the maximum you can achieve with the single agent ADT, that is the agonist or antagonist. With docetaxel, there is again rise in the sum of the median overall survival months, that is 41, close to 40 to 44 months. With the ADT plus abiraterone, again, it has shown significant improvement, that is close to 50 to 56 months. And if you combine, that is a triplet, that's the ADT plus docetaxel plus abiraterone, it has shown that approximately the median overall survival close to 5 years. So to conclude this, adding this abiraterone to ADT significantly improved the radiological PFS. And again, the overall survival was also improved with the 25 reduction in the risk of death. And this benefit translated the median lifetime gain of more than 1.5 years for men with a high volume metastasis. Toxicity was as expected, but there was no apparent synergic side effect from this combination of, that is ADT along with docetaxel along with abiraterone. So I'm not going to detail this. Another drug or darolutamide that is can be combined in the along with the ADT. So again, it has shown that patient with a high volume disease, they tend to do, but this triplet combination did a pretty well in a patient who has a high volume disease as compared to the low volume disease. So similarly, side effect profile and for this trial, this combination of this darolutamide in combination with the ADT and docetaxel, there is improved OS compared with the ADT and docetaxel. And this improved OS despite a high rate of subsequent life-prolonging systemic therapy in the placebo group. And it was consistent along all the pre-specified groups. And again, this darolutamide also significantly improved the key secondary endpoints, that is including time to castration resistant, time to pain progression, and first skeletal related events, and the time to first subsequent antineoplastic. So a combination of this drug in with ADT and docetaxel should become a new standard of care for the patient with the hormone sensitive metastatic prostate cancer. So this is a different hazard ratios for the combination of drug along with the ADT. And you can see there is no clear evidence of superiority of one agent over the others, and there is no direct inter-agent comparisons. So basically the treatment study depend upon the extent of disease and the patient comorbidity and duration of response to the ADT and the cost and availability of the therapy. So you have to decide whether in high volume to docetaxel, abiraterone or enzalutamide, and you can give only a single agent oral therapy along with the ADT. And if it is a high risk disease, again, you have to think about of the addition of the chemotherapy. A patient is having a severe symptoms, docetaxel can be you can use any of the oral drugs. And other things you have to take into consideration when planning the therapy for the patient with the metastatic hormone sensitive prostate cancer. So this is a graph, the flow chart showing how can you incorporate different drugs at a different point. So this is ancient management of the metastatic hormone sensitive prostate cancer. And we have this is all the repetition of the previous slides. So thank you for your patience listening. I think now we can discuss if you have any questions.
Thank you, sir. Thank you for this presentation. Sir, do you have used in your practice apalutamide?
Yes, I have used.
So
The
any
thing is
difference?
that apalutamide can, if you are using this apalutamide, has to be given a hormone sensitive. Like you can use abiraterone or enzalutamide in the castration resistant, but apalutamide till the data is for the hormone sensitive. So if you have choice, you use this drug first rather than using it in the later line when you are having already used abiraterone or docetaxel, or you have used the enzalutamide.
Okay. Thank you, sir.
Okay, thank you so much.
Hello, good evening, sir. Welcome.
Yes. Good evening, Piyush, and thank you for this opportunity.
Thank you, sir, for this agreeing to this presentation. And we know that Dr. Deepak is a consultant in Indus Hospital. So, sir, we'll be discussing regarding metastatic RCC, the medical oncologist perspective. Over to you, sir.
Yeah, thank you so much. And next slide, please, Geetika. Okay, it's under my control, or you will be moving the slides, Geetika?
Sir, Abhimanyu run कर रहा है आपका PPT ना?
Abhimanyu, please move the slide, please. So this is the Indus Hospital where do I work, and in Derabasi as well as in Mohali. So today we will be shortly discussing about the metastatic RCC. Now we know that immunotherapy has become a standard of choice in low risk as well as the intermediate and the high risk. So we will be talking the risk stratification, clear cell RCC, and role of cytoreductive surgery, and second line therapy and non-clear cell RCC, summary and conclusion. Abhimanyu, next slide, please. So basically, risk stratification is very important. There are two types of risk stratification which we do. One is the IMDC, and earlier we used to do the Memorial Sloan Kettering based risk stratification. But now the IMDC is the standard of these are standard risk stratification which we do for every patient with a metastatic RCC, which include the 6 components: the time of diagnosis less than 1 year, KPI scoring less than 80, and low hemoglobin less than 10, and high calcium more than 10, and high platelet upper limit of normal and high neutrophil. So majority patient in our Indian scenario, they either they fall in. Why it is so important to risk stratify? Because of the survival benefit. Next slide, please, Abhimanyu. Abhimanyu, next slide. Yeah, as we can see that uh, overall survival for the favorable risk category patient, it is approximately 70%. 70% till the end of 5 year survival is 70%, and while in the intermediate it goes down to up to 30 to 40%, while in the poor risk it just come down to like 3 years only for 20 to 30% of the patients. Next slide, please. So these are the clinical the NCCN guidelines which state that first line therapy for clear cell histology for favorable as well as the poor and intermediate. As we can see that VEGF inhibitor plus IO are the backbone. Is there anything else? Favorable and poor and intermediate risk, and as we can see that IO are the backbone, whether it is a favorable or the poor or intermediate risk. Next slide, please. So and this is a ESMO schema, and ESMO clinical practice guideline update on the use of immunotherapy in the early stage as well as advanced renal cell carcinoma. In the advanced clear cell, a favorable risk score, lenvatinib, pembrolizumab, or pembro, exitinib, cabozantinib, and nivolumab. Intermediate poor risk IMDC groups. This is nivolumab and nivo-ipi. And although we rarely use this combination because of the toxicity concern, but in conclusion, that IO remain the backbone of every every risk group. And once the patient has been progressed, when the patient is on IO, so we can use any VEGF inhibitor that has not been previously given, either exitinib or cabozantinib, lenvatinib, everolimus, or pazopanib, sunitinib, and tivozanib. Next slide, please. So these are the basic pathway and current drug in the metastatic RCC. Why these are VEGF inhibitor are important? What are the pathway they do inhibit? As you know, the major pathway inhibitors are FGFR, VGFR, PDGFR, and AXL and CMET. Cabozantinib has an advantage of inhibiting the both VEGF receptor as well as CMET as well as the AXL AXL receptor, while PDN and mTOR inhibitors, nivolumab inhibit both PDL1 and PDL2, as well as and mTOR inhibitor also inhibit the everolimus and temsirolimus, which subsequently inhibit the protein synthesis and nucleotide synthesis, lipid synthesis, and anabolic. Next slide, please. So why it is important to combine VEGF inhibitor with PDL1 with PDL1 inhibition? So immunologically elevated VEGF may inhibit the dendritic cell maturation, causing the immunosuppression, and VEGF inhibition may reduce the number of Tregs and tumor-invading myeloid-derived suppressor cells. So anti-VEGF therapy may prime better effect with the anti-PDL1 anti-PDL1 therapy. So that's the reason it is important to combine IO with the VEGF inhibitors. Next slide, please. So these are the basically five trials, phase 3 trial, which has proven the efficacy of IOs as comparatively to the single agent VEGF inhibitor. These are Keynote 426, Checkmate 9ER, Checkmate 214, and Clear Study, and avelumab axitinib versus sunitinib, and IM Motion 151, in which atezolizumab was sunitinib. which was not approved. Next slide, please. So starting with next slide, Abhimanyu. So starting with keynote 426, in which Pembro plus Axitinib was compared with the standard of care Sunitinib, and eligibility criteria remain stage 4 clear cell RCC, no previous systemic therapy, KPS more than 70, measurable disease as per RECIST criteria, provision for tumor sampling for biomarker assessment, and adequate organ function, and of course the IMDC risk group and geographic region. North America versus rest of the world versus Western Europe. Next slide, please. So we can see in the graph with the lines are separating very initially, and there is a clear cut overall survival with the intention to treat population with pembrolizumab plus axitinib versus sunitinib. And at the end of 1 year, there is a 90% overall survival as compared to 79%, while at the end of 2 years, it was 74%, 66 in the sunitinib arm. And PFS, there is a clear cut PFS advantage, 60% versus 48% at the end of 1 year, and while at the end of 2 years it was 38% versus 27%, with a very good p-value of less than 0.0001. Next slide, please. Second trial, Checkmate 9-year trial, which are presented in the ESMO 2020, in which it was again a phase 3 trial in which nivolumab plus cabozantinib was compared with the sunitinib arm. Again, the same inclusion criteria: clear cell component, any IMDC risk group, and previously untreated or advanced metastatic RCC, in which nivo was nivo plus cabozantinib was compared with the sunitinib, and treatment was going on till the progression or unacceptable toxicity. Next slide, please. So in the there was a clear-cut progression PFS advantage in intention to treat and a subgroup analysis in the Checkmate 9-ER. We can see that their PFS was in the nivo plus cabo was it is 16.6 months, while in the arm of sunitinib it was 8.3 months only. So nivo and cabo showed consistent PFS benefit over sunitinib across key baseline characteristics, including IMDC risk status, tumor PD-L1 expression, and bone metastasis. Next slide, please. So in the overall survival also, there is a clear-cut median overall survival advantage seen in the nivo and cabo arm as comparatively to the sunitinib arm, and and nivo plus cabo showed consistent overall survival benefit over sunitinib across key baseline characteristics, including IMDC risk status, including PD-L1 expression, and bony metastasis. Next slide, please. So there is another phase 3 trial in which lenvatinib was combined with pembro or everolimus or sunitinib as a first-line treatment on the patient with advanced RCC. It was a clear study. It was three arm was selected, in which lenvatinib plus pembrolizumab, lenvatinib plus everolimus, and sunitinib alone, and eligibility criteria remain the same more or less, and primary endpoint was a PFS by IRC. Secondary endpoint was overall survival, safety, and quality of life, and key exploratory endpoints were biomarkers and DOR. Next slide, please. Duration of response, and we can see from this graph that lenvatinib plus pembro has a PFS advantage of 23.9 months versus 9.2 months in the both arm. There is a clear-cut advantage of 14 months when we combine the lenvatinib with the pembrolizumab. Next slide, please. So overall study in the overall survival advantage also, when the len and pembro was combined, and when it was compared to the single sunitinib, there is a clear cut advantage of overall survival. It was with a p value of 0.005. Next slide, Abhimanyu. Yes. So conclusion was clear study. Lenvatinib plus pembrolizumab demonstrated a significant PFS and OS overall survival and overall response rate versus sunitinib. Lenvatinib plus everolimus demonstrated significant improvement in PFS, but not in overall survival versus sunitinib. The safety profile of lenvatinib plus pembro and lenvatinib plus everolimus was consistent, with each drug non-profile and manageable as needed through dose modification. These results support lenvatinib plus pembro as a potential first-line treatment in the patient with the advanced RCC. So coming to another trial, CheckMate 214, nivolumab plus ipilimumab versus sunitinib for untreated advanced RCC. Piyush, how many of us has used this nivo-ipi combination in RCC? I mean, I have not used so far.
Sir, no, I haven't used.
In
I
melanoma?
In melanoma, no.
Okay, we have not used. So again, the patient treatment naive advanced RCC, measurable disease with KPS of more than 70%, tumor tissue available for PD-L1 testing, randomization 1:1, 3 mg nivolumab with 1 mg per kg ipilimumab IV Q3 weekly for 4 doses, then only nivolumab every Q2 weekly. Arm B was only 50 mg sunitinib. Treatment until the progression and unacceptable toxicity. So in the CheckMate 214 and nivo-ipi versus sunitinib, the outcome was overall response rate was 39% versus 33 in sunitinib arm. PFS was 12.5 versus 12.3, and median overall survival was it was approximately 46.3 months versus 38.4 months in the sunitinib arm. Next slide, please. So overall survival response by IMDS risk category, outcome in the favorable risk patient, nivo-ipi nivo-ipi combination was overall response rate was 29 months versus sunitinib it was 54 months, while in the PFS median PFS was 17.8 and in the sunitinib arm it was 27.7 months with a hazard ratio of 1.62 and a p value of less than 0.01. Next slide, please. So another study, Javelin Renal Avelumab plus Axitinib in treatment naive advanced RCC. Javelin Renal 10 study design was treatment naive RCC, clear cell component, more than one measurable lesion as defined by the RECIST criteria. Tumor tissue available for PD-L1 testing in the ECOG PS0 to 01 and geographic region we know. Avelumab was given 10 mg per kg Q2 weekly plus sunitinib 5 mg versus sunitinib. The primary endpoint was PFS, PD-L1, and overall survival in the PD-L1 positive group. Next slide,
So
please.
request you to kindly conclude in 1 minute.
Yes, we are concluding. Medium PFS was avelumab plus axitinib was 13.8 months, while in sunitinib it was 8.4 months, and overall survival, there was no forever in plus axitinib arm. Next slide. Abhimanyu, next slide. It's a T trial. Next slide. Come to next slide. Yeah. Next slide, please. These are so first line in the summary. Wait, go to slide. So risk stratification is very important. Good risk patient, those with favorable intermediate can have a survival for many years, up to 48 to 60 months at least. Availability of new IO combination creating paradigm shift in the management of metastatic RCC. Next slide, please. Whether there is a role of cytoreductive surgery. Next slide. Next. Yeah. So in the Caramina trial, it has clearly benefit. There is a no advantage of doing a nephrectomy in this setting, whether it is a favorable group or whether it is intermediate or a high risk group. Although there is a no survival advantage, no PFS advantage has been seen. Next slide, please. Next slide. So sunitinib alone is a non-inferior to cytoreductive nephrectomy. Clinical benefit was significantly higher in sunitinib arm alone. Cytoreductive nephrectomy should no longer be considered as standard of care in the metastatic RCC. Next slide, please. At least when the medical treatment is required. Next slide. So there are few unanswered questions, but now the conclusion is that there is no clear-cut indication for the nephrectomy in when there is a medical treatment is required. Next slide, please. So updated overall survival in intention to treat population, surgery plus sunitinib alone, and median follow-up of the 5 years. There is no advantage seen from the graph. The Kaplan-Meier curve, 36 versus 26 at the end of 36 months. There was a 0.6 advantage and 20 slide, please. Next slide. Yeah. So median overall survival, nephrectomy plus sunitinib, it was 13.14, and while in the sunitinib was 25.2, but coming to the intermediate and high risk, it was 17.6 versus 13.2. So sunitinib is always recommendable for the for the high risk or the intermediate risk population. Next slide, please. So sunitinib alone, median overall survival in months, it was sunitinib and delayed nephrectomy of 48.5 months, while sunitinib alone was 15.7 months with a hazard ratio of 0.34. Yes, next slide, please. Conclusion: with longer follow-up, 16.1 months, Cambrian trial confirmed that cytoreductive nephrectomy is not as superior to sunitinib alone in the intention to treat population, both with MSKCC and IMDC risk group for treating MRCC. This update confirmed that overall CN should not be considered as a standard of care. Next slide, please. Only 2-3 slides are remaining. Conclusion 2. CN might be beneficial for only one IMDC risk factor, especially in case of one metastatic site, and number of metastatic site per se is not helpful to define candidate. Delayed nephrectomy after initial system therapy in good responder patient is associated with the long overall survival, supporting this approach as a good therapeutic strategy. Yes. So how many are you are posting the patient for the secondary nephrectomy? No. The choice of treatment for metastatic RCC after disease progression varies depending upon the treatment received in the frontline setting. Next slide. So so it all depends upon the what are the treatment patient receive, strength of evidence and toxicity profile, patient comorbidity, and patient and physician preferences. Next slide, please. Come to the last slide, please. Last slide. So these are the basically options whether the patient receive IO therapy in the in the first line, or not receive, patient who has received IO, then they will be posted for VEGF inhibitor. If the patient already received VEGF inhibitor, they should be like they can be subjected for the IO, but there is a no standard preferred reason so far in the both the groups. Next slide, please. So these are the summary of second line RCC, but response rate remain the decimal 10%, 2%, and 23%, 12%, and 8% maximum. So next slide, please. In the check, so these are the nivolumab phase checkmate 025 study, and this patient who has already received 1 or 2 anti-angiogenic therapy, less than 3 total prior systemic regimen. It was compared with the nivolumab versus this everolimus. So next slide, please. So primary endpoint overall survival was met with the nivolumab and the and versus the everolimus. The progressive with an overall survival was 25 months, and while the 19.6 months in the everolimus arm, PFS was 4.6 versus 4.4, and overall response rate with the nivolumab was slightly superior, 25% versus 5%. Next slide. So again, please go to next slide, please. Next slide. Again, PF. Next slide. Yeah. Again, this is the last. So these are the choice of treatment after disease progression. Who a patient were initially treated with EP plus nivolumab, they can go ahead with any of the VEGF inhibitor, lenvatinib, everolimus, axitinib. Patient who were initially treated with immunotherapy plus VEGF, they can go with the VEGF inhibitor which was not initially been used, cabozantinib, everolimus, or lenvatinib or everolimus. Next slide, please. Next slide. Yeah. So I mean, non-clear cell. There is I mean, these are very rare, and there are many subtype like papillary chromophobe, clotting that medullary, and translocation RCC, and each is associated with their own histopathological, genetic, and hereditary alteration. But it only approximately it comprise only 5% of the RCC. So pathogenesis remain the same, such as upregulation of VEGF inhibitor, and HIF via VHL or mTOR pathway is not applicable in the non-clear cell RCC, and overexpression of pathways such as MET signal have been explored in subtype of papillary RCC, which account for the 10 to 15% of RCC. So there is not they are traditionally underrepresented in clinical trial, and their treatment is not well studied. Next slide, please. So come to the last slide, please. Uh, so management of advanced RCC continue require the multidisciplinary approach. Decisions are based on risk stratification and the balance between toxicity and efficacy. Combination therapy remains the standard in front line. Incorporation of IC-based therapy in frontline treatment of metastatic RCC are drastically alter the clinical trajectory. Cytoreductive nephrectomy is only helpful in selected group of patient. Treatment option of second line and beyond is previous treatment, toxicity profile, and patient comorbidity, patient and physician preference, financial concerns. Not all the non-clear cell are the same histology. Directed therapy will be critical on to advancing care. Further trial on novel agent biomarker study based therapy and focus on treatment-free interval will define the MRCC treatment over next few years. Next slide. Yeah. Thank you, Dr. Piyush, for giving me this opportunity. And
thank you, sir.
Thank you, sir. So next, I would like to invite Dr. Piyush Mehta to moderate the case-based discussion. Over to you, sir. Kindly invite your panelist.
So I would like to invite Dr. Deepak, Dr. Ankur, Dr. Ghazal. I think Dr. Ghazal is she's not well. So,
Yeah, good evening. I
Dr.
request to
Suhas,
all panelists, please kindly rename your name.
Dr. Suhas. Yeah, thank you, sir. So shall we start?
Yes, sir.
Yes, sir.
Okay. So please, if you could run my slides.
Abhimanyu, please upload the slides.
Sharing just 1 minute.
Make it full screen, yeah. So this session is sponsored by the Merck. So I will be discussing a case of RCC, which we have treated in our hospital. Next slide. So a 69-year-old female, she presented to us with hematuria, and she had a past history of nephrectomy in 2018 September. She was on regular follow-up. She remains asymptomatic till the time she came to us in July 2022. And she came with a complaint of back pain, which was radiating to both the limbs. She had difficulty in walking and pain in the flank, and weakness and numbness in bilateral lower limbs. And also she had weight loss, decreased appetite, and low-grade fever. Next slide. So the patient was evaluated because she had back pain. So MRI spine was done, and that was done on July 22. That patient had a large soft tissue mass, and which was abutting compressing the posterior element, and it was extending into the spinal cord, causing thecal sac compression. But there was no any focal deficit, and no slight numbness was there, but there was no motor weakness. PET CT was also done, and which showed deposits in the D9, D10 vertebra, as well as a deposit in the scapula also. So we did a biopsy from the spinal deposit, and that comes out to be like metastatic from the clear cell carcinoma. IHC was supportive. And next slide. So patient was started on, she was in IMDC intermediate risk criteria. Patient was started on injection avelumab 800 milligram along with axitinib 5 milligram. She was initially started in a dose, once a daily dose, but she even didn't tolerate that dose. So we gradually reduce it to 2 milligram, and then again, as the tolerance increases, we increase it to 3 milligram twice a day, along with denosumab. So my question is, like, in this setting, what else we could have done as this patient? Like, I will tell you in detail what is happening. Even now, that patient is doing okay, but any different school of thought for treatment or for any other evaluation? Dr. Suhas?
Okay, so hi, Dr. Piyush. What we can think of, I think we could have thought of giving some amount of palliative radiation for the pain palliation part. That could have been done. and that may have helped. Even there are few studies which suggest that immunotherapy acts better after a short session of radiation, as it induces more of new antigens in the stream. So that could what I can plan for this patient above that.
Agreed, sir. So we also thought of giving radiation. Initially, we did a radiation oncologist consultation, and a neurosurgeon has also seen. So as the patient was having only pain and she was not symptomatic, so we decided to go with systemic treatment and to keep radiation as an option if any symptoms worsen or any in case of any worsening or non-improvement of symptoms. Dr. Ankur, your opinion?
Yes, sir. Hi, sir. Good evening, sir.
Evening, good evening.
Hello. Hi, sir. Good
Yes,
to
yes,
see you
you're
after
audible.
such a long time, sir.
Yeah, same here.
So, sir, in our institute, basically, as sir also said that the part of radiation is very important, I think. But it's the right call if the disease worsens or if there is a motor weakness, then radiation part is more important. In our institute, we usually also follow this IU plus TKI and protocol, but we usually the combination of drug we use is, if the patient is fit enough, then we go for Nivo plus Cabo. And if the just as your patient is 70 years old, so we would prefer Pembro plus Exitinib, as you have also chosen.
Yeah. Dr. Deepak?
Okay. Good evening.
Good
So
evening.
basically, Piyush, there are 2-3 points regarding this case. Obviously, we have done the IMDC staging also, and obviously intermediate report will be there. But as we know that in the last slide, Dr. Deepak Singh has told us regarding multiple IO-ITK combinations are there. As we know that initially it start with Pembro-Exe only, and then there comes the era of Nivo-Cabo, and after that it's come Len-Pembro. And this is the fourth one in line. Avi and Exitinib is there. If you ask me personally, as we know that among all the TKIs, after Sunitinib and Pazopanib, Cabo is everyone's choice. If someone want to do single TKI, is Cabo, everyone will start with that. And keeping the immunotherapy in the second slot, I will just choose Cabo as a TKI backbone. Obviously, with that, Nivo is the perfect combination for that for my patients. And if you ask regarding clear trial, Len versus Pembro, I think only one problem is with that trial is that 18 mg dose is there with Len. And I think most of our patients are not able to tolerate this much dose. And obviously, if we decrease the dose, we'll decrease the efficacy and the PFS benefit also. So as it's obviously Avelumab has shown a good response in bladder tumors. And obviously, I think it's especially made for general unit tumors also. But I love to use this regime. But till now, I am continuing one patient on Nivo-Cabo, and to certain patients, Pembro-Exe, what is going on for last 2 years. But in the future, when it comes to us, I will definitely use Avelumab plus Exe in my patients.
Good. So the patient was started on Avelumab and Exitinib. Next slide. So initial scan was done, which showed a slight increase in the tumor size, but patient was not at all symptomatic. So we thought it to be a pseudo progression. We discussed it with nuclear physician also, and we continued with the same treatment. As the patient clinically has improved a lot, she was asymptomatic. Her weight has become almost normal, and in all parameters, she had improved clinically. So, but because of slight increase in the size, we thought it to be, but the SUV was not increased. We initially thought it to be a pseudo progression, and we continue with the same treatment. Next slide. So a repeat PET scan was done. As we can see, this was the same scan, like comparison. Like after that, we did a repeat scan, and we can see that the size and the activity that has if you see in the November and then in the July, we can see that increase. And next slide, this thing that's. So another scan was done in February after November, which showed no evidence of any metabolically active lesion, and MRI spine was also done, which reveals just disc herniation, and patient was continued on the similar treatment, which is Avelumab and Exitinib in a dose of 5 mg along with Denosumab. Next slide. Yeah. So we can see in this that in the first in the lower one, we have July 2022 scan, and then in the November we can see the increase in the size. Then in the February we can see the decrease in the size and the activity. So this concludes that it was a pseudo progression, and the patient was continued on the same treatment. Next slide. Repeat scan was done in the September of 23, where it was a stable disease. Next slide. And patient was continued. So the patient has been on the same treatment. Even she came today. She had after this, her last dose was in September. After 25 cycles, she received 3 more cycles, and then a PET scan was done, which was suggestive of slight increase in the size, and there was a spinal cord compression. So radiation was done. And now the next question is, now as the patient is otherwise clinically stable, she had a increase in the back pain, and she repeat assessment was done, MRI was done, and she had spinal cord compression. We took a radiation oncology consultation and a neurosurgery consultation. So neurosurgeon and the radiation oncologist, the MDT discussion in the tumor board, and plan is to give radiation palliative RT to the spine. So palliative RT that has been completed yesterday. So patient came to me today for further treatment. So Dr. Suhas, what is your opinion like for further treatment?
So as we have already exhausted the IO-TKI combination, the next option we have is an IO-IU or a TKI as a single agent. So if the affordability allows, then we may try for Nivo plus EP, but I will prefer single agent cabozantinib, as Dr. Deepak has already mentioned. And if I get a good response over in the same, then I may consider Nivo EP later on.
Okay. Yeah, so I have planned this patient for cabozantinib. Dr. Ankur, your opinion?
Right, sir. So, sir, as it is a oligo progression, sir, and we have already addressed it. Is it fine to continue with this avelumab axitinib combination? Otherwise, also, if it's not as per you have also advised for cabozantinib, this is the next best option, I think. But one of the ways is also that to continue with avelumab axitinib, as it's only a oligo progression. That's what I think.
That's a very valid point. That's a very valid point. It's an oligoprogression. We may wait, but what we need to do is that we need to assess the patient more frequently, like at 6 weeks or something like that, just to understand if the disease is again progressing or not. If the disease remains stable after the radiation part, then obviously we may carry on with avelumab and axitinib.
Yeah. So because I have seen many such patients during my training, like where patients with RCC, they had oligoprogression, and we just tackle the oligoprogression with mostly radiation, and we continued with the same treatment. If the patient was on TKI, we continued with TKI, and if before the patient was on either TKI with IO, we continued the same, and along with just either surgery or either radiation to the local site.
Yes, we can carry on. The only thing which actually is bit worrisome is that the patient started developing features of spinal cord compression. So that is where I would like that there should not be anything which may increase the mass, whether it is a pseudo progression or a progression. So that is where I like to change my therapy to another TKI, which is much more active. So that's why I'll still like to carry on with cabozantinib. And may reintroduce avelumab and axitinib later on also, just to be sure. Once the cabozantinib takes the call and it decreases the disease load, then we can again reintroduce the same.
Yeah. Dr. Deepak, your thought on this?
Dr. Puch, actually, there are 2-3 things regarding at present. As you told that the patient's spinal cord compression features are started up, and I think you're taking both opinions of radiation and neurosurgery. And I think radiation is the better choice in this case as per the MDT. But as such, I think neurosurgery is typically out of question they are not able to intervene this patient or something?
No, they told that if the life expectancy is more than 1 year, then only in that case they will operate. Otherwise, they.
You think, but I think it is more than 100 is there. I think so.
But we can't say that it is more than 1 year or it is less than. Matlab, to the life expectancy, but
I think it's not some invasive procedure there. It's a very, I think, routine procedure of neurosurgery intervention required, and I think this will give us the sure shots. Risk of having SEC, it will be out of question. And although you have chosen RT in this case, I think the risk of compression is also out at present. We can continue the same disease, but as Dr. Suhasa told us, we have to examine the patient both clinically and radiologically more frequently, and he has to come to hospital every weekly or 2 weekly, and we do imaging exactly 4 to 6 weeks. And if some sign of clinically worsening or radial worsening is there, you have to change the drug. Although it's a little bit tricky, but I think radiation has given us some time to adjust, and we can give 2-3 months to decide for future therapy.
So this patient had adrenal insufficiency with immunotherapy. She had low loss of appetite and nausea with fatigability, vomiting, nausea. So we did a serum cortisol, TSH, and all this workup. Her cortisol was like 0.2. So we took an endocrinology consultation, and patient was started on steroid replacement. After that, patient got better. So that's why I choose to use cabozantinib. Otherwise, if there had been no such toxicity, so I think that I would have continued with avelumab and imatinib.
So keeping all the things in consideration, I think you are better than the choice. Start TKI, and we can assess, and we can reintroduce any kind of Nivo EP, something like that in future if disease persists or not.
Yeah.
So, sir, I have a question actually. So, sir, if she had this toxicity, so in later on in life, we can try immunotherapy again. So, is it possible? Just I have just question this.
We can try, and even we can continue because we have managed the toxicity.
Right.
So this patient developed this toxicity after say 7 to 8 cycles of starting treatment.
And then we have continued. Then we
have continued, and the patient remained asymptomatic after steroid replacement. She becomes absolutely fine. So I think that we can continue with the similar regimen, but because of slight toxicity with, she also had accelerated hypertension with exitinib initially.
Oh.
So I thought to just switch over the regimen because the patient and the attendant, they were like, bit key, this was just because of the medicine that she's having all problems. So I've tried, I've counseled them, and I will change it to cabozantinib.
Right. So it's a very complex decision actually. It's involved many factors.
Yes. So next slide. So it's just like Dr. Deepak has already discussed a lot. So I will just run this through a bit fast. So we have like newer drugs and mechanism of action in metastatic RCC. We know the drugs. Initially, we have like interleukin, and then we have TKIs acting on different receptors like MET, XL, VEGF, PDGFR, FGFR, and then we have anti-PD-L1, and we have CTLA4 antibodies, and then drugs targeting mTOR pathway. Next slide. So this is a field of changing RCC treatment. Initially, interferon, interleukin, sorafenib, then sunitinib. Then it's a very common slide. I think we all must have seen this slide in many times. Temsirolimus, then pazopanib, cabozantinib, Nivo EP, then avelumab, exitinib, pambro-exitinib, Nivo cabozantinib. So a lot of these combinations, and now we have another a class of drugs which coming up also. Like we have now drugs acting upon the VHL system. Next slide.
So request you to conclude in 2 minutes.
Yeah. I'm just concluding it in 2 minutes. Next slide. Just a second, I think. I'm not able to see any slides.
Slides are visible, sir. Suhas sir, the slides is visible.
Slides are visible, yes.
Okay, but I'm not able to see.
So basically about the Javelin Renal 101.
Yeah, now they're visible. Yeah. So Javelin 101 renal. So next slide. So this has been discussed by Dr. Deepak also. So next slide. So we know that it is a combination which have been compared with sunitinib, and the benefit has been seen. And the next slide, I think that Dr. Deepak has already discussed this in detail. Overall response rate with avelumab and exitinib in a range of 52% compared to sunitinib, where it's around 27%. Next slide. Yeah, so the PFS benefit was seen across in all age groups with advanced RCC, including in the elderly patient. Next slide. 45% reduction in the risk of disease progression or death, hazard ratio of 0.55. Next slide. So the separation of curve, we can see this continues even in the follow. And with avelumab and exitinib, the median overall survival is not yet reached, while in sunitinib it's 37.8 months. Next slide. So it even has a role in the sarcomatoid variant, where we can see that the median PFS of 7 months compared to 4 in the sunitinib arm. Next slide. So use of avelumab and exitinib in the treatment of ESRD patients. Yes, these patients with RCC with end-stage renal disease, they have been treated with avelumab and exitinib. Next slide. So it has a longer median PFS and better overall response rate, lower discontinuation, consistently better PFS, and faster median time to response, which is 2.7 months versus 4% compared to sunitinib, and lesser need for a high dose steroid use. Next slide. So the current first line, so this is the trial which Dr. Deepak has also discussed. So in the control arm, we have sunitinib, and in Javelin Renal 101, we have avelumab with exitinib, and Keynote 427 with pembro exitinib, then Clear with pembro lenvatinib, and then Checkmate 9ER with nivo cabozantinib. Checkmate 214 is nivo ipi compared to sunitinib. Next slide. This is a slide which I just want to show that in patients in favorable risk profile, 21% of the patients, the overall response rate was better with, if we see in favorable profile, 76% versus 46%. But if we see with another in the Clear, it was 68%. In Checkmate 9ER, it was 66%, and 68% in pembro exitinib. But in patients in favorable profile, it is better, the response rate with avelumab and exitinib. But in intermediate risk patient, it is best for the pembro lenvatinib, and which is 72% versus 28%, while in case of avelumab and exitinib, it is 60 versus 31. So in patients in favorable risk, this drug combination, like avelumab and exitinib, that fares better than the other combinations which we have. Next slide. So this is a side effect profile, like drug-related toxicity that is less compared to pembro exitinib arm, and the steroid use that is least in this arm, and the pneumonitis rate is less compared to the other combination, as it is maximum with the nivo-ipi combination. Next slide. So this has been discussed. Next slide. So the benefit. Next slide. I think you are going backwards. This is we have discussed already. Next slide. Next slide. Next. Yeah. So main thing which I want to highlight was that in patients with favorable profile, this drug combination that does better compared to other drug combinations. In our patient, it was intermediate risk. Still, we use this drug, but because of some other issues that we haven't used other combination of immunotherapy with TKI. But in favorable, definitely overall response rate was better compared to another drugs. Thank you. So I think I am delayed for this. Thank you, Dr. Suhas. Thank you, Dr. Ankur.
Thank you, Dr. Piyush. It was a great discussion. Thank you, Dr. Ankur.
Yeah.
Thank you, sir. Thank you.
Okay. So can we proceed on to the next session?
Yes, sir.
So next is Dr. Suresh Patel.
Yes, sir. Next session is Dr. Suresh Patel session, sir.
Good evening, Dr. Suresh, and welcome again. And I think we know each other. Medanta, yeah. So Dr. Suresh, sir, will be discussing regarding CDK4/6 inhibitor, ribociclib. Over to you, Dr. Suresh.
Am I audible?
Yes, yes, sir.
Thank you, Dr. Piyush. So, can anyone share my slides? I would like to thank Dr. Piyush and the organizers and Novartis for giving me the opportunity to discuss the topic of evolving landscape of CDK4/6 inhibitors and its implication in clinical practice for HER2, hormone receptor positive, HER2 negative metastatic breast cancer patients. So a warm good evening to everyone. Next slide, please. So this is my disclaimer. Next slide, please. So while considering treatment for advanced breast cancer patients, what is our primary goal? So as we know, our primary goal is to provide a good overall survival to the advanced breast cancer patients. So this is our primary goal. Next slide, please. So apart from providing good overall survival, we have to also consider to provide a good quality of life to our patients. So what is the definition of overall survival? Overall survival is considered as the most reliable cancer endpoint, and it is defined as the time from randomization until death from any cause, and is measured in the intent to treat population. And it is considered as the gold standard for assessment of efficacy of cancer therapies in the and is evidence of statistically significant and clinically meaningful improvement in overall survival and quality of life. Next slide, please. So now we are going to discuss further whether CDK4/6 inhibitors are the game changers in the management of hormone receptor positive and HER2 negative advanced breast cancer or not. Next slide, please. So we have three fancy drugs in the market, which are CDK4/6 inhibitors. First being ribociclib, abemaciclib, and palbociclib. So what is the study for ribociclib? We have three studies: Mona Lisa 2, 3, and Mona Lisa 7. Mona Lisa 2 was used in first-line treatment of breast cancer patients with combination therapy with endocrine partner being aromatase inhibitor, and the patient population was no prior systemic therapy for the advanced disease. In Mona Lisa 3, it was for first-line and second-line therapy, and the combination partner was fulvestrant. And in this study, the patient population was no prior therapy for advanced disease and patients who have progressed after endocrine therapy. In the Mona Lisa 7, it was used for first-line treatment in premenopausal patients, and the combination was with aromatase inhibitor, and the patient population was no prior endocrine therapy for advanced disease. For abemaciclib, we have two studies with Monarch 2 and Monarch 3. Monarch 2 was first line and second line treatment with combination fulvestrant, and it was used in patients progressed on or after prior endocrine therapy. Monarch 3 was used for first line therapy with combination with aromatase inhibitor in the patient population of no prior systemic therapy for advanced disease. In palbociclib, we have two studies of one is Palomar 2 and other one is Palomar 3. Palomar 2 was used for first line therapy with combination with aromatase inhibitor in patient population of no prior systemic therapy for advanced disease. Palomar 3 was used for combination therapy in first line and second line therapy in combination with fulvestrant in patients who have progressed on or after prior endocrine therapy. First line of chemotherapy for advanced disease was allowed. Next slide, please. So now we are going to look regarding the PFS benefit. You can clearly see that all the studies showed a significant PFS benefit. Next slide, please. So when we look whether there was any difference in the overall survival benefit, when you look at all the comparison of the studies, you will come to know that overall survival was seen only with ribociclib and abemaciclib based therapy. And the overall survival data is still pending for Monarch 3 trial, and the overall survival with ribociclib was the highest, which was around 64 months as compared to the other studies. Next slide, please. So can a benefit in PFS will be a predictor for overall survival benefit also? We are going to discuss further in the other coming slides. Next slide, please. So why achieving a statistically significant difference in overall survival in hormone receptor positive HER2 negative advanced breast cancer clinical trial has been challenged? This is due to the following reasons. Over the past decades, few studies have shown that with targeted therapies have reported significantly improvement in overall survival. However, with the challenges in achieving overall survival in advanced breast cancer, PFS has become a clinically meaningful endpoint for advanced breast cancer trial. However, improvement in PFS has not consistently translated into an overall survival benefit. Also, achieving an overall survival benefit may be difficult in advanced breast cancer, especially in the earlier lines of therapy due to several factors, including the availability of several lines of subsequent therapy, leading to a use of endpoints such as PFS in these trials. Next slide, please. So when we look at the Paloma trials, you can see that change in PFS was not predictive, was not further continuing with significant improvement in overall survival. In the Paloma 2 and Paloma 3, you can clearly see that the Kaplan-Meier survival curve clearly shows that there was a significant PFS benefit. But when we come to the overall survival curve, the overall survival data was not statistically significant. Next slide, please. So what could be the reason for this? So now we are going to discuss it in form of hypothesis. Next slide, please. So in hypothesis, we are going to discuss, next slide, please. First point could be the different patient population in the trials. Next slide, please. Second hypothesis could be the different post-progression treatment in the trial. And the third hypothesis could be different pharmacological characteristics of the CDK4/6 inhibitors. Next slide, please. So we are going to discuss the first hypothesis, which is the different patient population in the trials. So what we do a matched MAIC, which is matching adjusted indirect comparison to compare the relative effectiveness of the treatments according for the difference in population. So when we do comparison with the Mona Lisa 2 and Paloma 2 regarding the patient population in the trial, you can clearly see that almost both the studies have similar type of patients. So on MAIC, it was found, next slide, please. So they did pre-matching, matching, and then they did the balanced population analysis. Next slide, please. Next slide, please. So it was found that the PFS benefit was found in both the studies with MONALEESA 2 and PALOMA 2. Next slide, please. However, the overall survival data favored the ribociclib and aromatase inhibitor arm, with a hazard ratio being 0.68, showing a significant overall survival benefit for ribociclib plus letrozole therapy. Next slide, please. Next slide, please. So now we will be discussing the second hypothesis, which is the different post-progression treatment in the trial. Next slide, please. So on pooled analysis of the post-progression treatment after first-line ribociclib endocrine therapy in the patients with hormone receptor positive HER2 advanced breast cancer in the MONALEESA 2, 3, and 7 studies. Next slide, please. It was found that the most subsequent therapies in the ribociclib, it was found that the most subsequent therapies differed between the arms for patients in the ribociclib and endocrine therapy was the most common, followed by chemotherapy and targeted therapy for patients in the placebo arm, and chemotherapy was the most common treatment, followed by endocrine therapy and targeted therapy in the placebo arm. So within the targeted therapy group, the number of patients receiving a CDK4/6 inhibitor as first subsequent therapy was greater for placebo as compared to the other therapy. Next slide, please. So in all treatment, in all treatment categories other than chemotherapy or other, the duration of first subsequent therapy was longer for patients who were treated with ribociclib as compared to placebo, which could be related to the carryover effect of the ribociclib in the ribociclib based arm. Next slide, please. However, when we come to the PALOMA 3, it reported similar numerically shorter duration line of therapy after placebo, and chemotherapy was the most common treatment after palbociclib. So carryover effect was not seen in the PALOMA 3 study. Next slide, please. So the second hypothesis could be due to the possible carryover effect of ribociclib. Next slide, please. So now we are going to discuss the third hypothesis, which is the different pharmacological characteristics of CDK4 and 6 inhibitors. Next slide, please. So as we know that in breast cancer, the CDK4 target is much more important as compared to the CDK6, as CDK6 inhibition is associated with the hematological side effects. Next slide, please. Also, CDK4/6 inhibitor have a different all the three when we come to the all the three CDK4/6 inhibitors, ribociclib and abemaciclib are more active against CDK4, and they are much more, so they target the breast cancer cells in a much better way, as seen by the head-to-head comparison of the three drugs. So abemaciclib and ribociclib have a much strong target for CDK4 as compared to palbociclib. Next slide, please. So ribociclib and palbociclib have fewer drug interaction with off-target kinases, and thus they have minimal side effects as compared to the abemaciclib also. Next slide, please. Also, when we come to the pharmacokinetics, you can clearly see that a clinically relevant doses and even ribociclib, but dose decreased level also, they have a much stronger CDK4 inhibition, as they act much better on the CDK4 target, as it is a potent CDK4 inhibitor as compared to the other drug CDK4/6 inhibitors. Next slide, please. So next slide, please. So this we have discussed that all the CDK4/6 inhibitors have different pharmacological characteristics, with ribociclib being a more potent CDK4 inhibitor and also is associated with much lesser side effects as compared to other CDK4/6 inhibitors. Next slide, please.
Sir, kindly conclude your talking points, please.
So next slide, please. Only three slides. So as you know, even NCCN guidelines clearly recommend as ribociclib being a preferred treatment option as compared to other CDK4/6 inhibitor. Next slide, please. Also, when we come to the ESMO guidelines, ESMO magnitude of clinical benefit, which showed that they have clearly mentioned ribociclib being a substantial benefit as compared to the other CDK4/6 inhibitors, with score being of 4 or 5 to the ribociclib therapy. Next slide, please. So now we come to the consistent overall survival benefit with ribociclib 2 in difficult to treat patients. So next slide, please. As we know, overall survival, so they did the analysis for overall survival in patients with visceral metastasis. It was found that patients with visceral metastasis who were treated with ribociclib have had a 19% relative reduction in the risk of death. And also the overall, it was found that 29% patients with liver metastasis had a relative reduction in risk of death. Next slide, please. So in pooled Mona Lisa study, median overall survival PFS benefit was seen even on more than or 1 equal to dose reduction. You can clearly see that the overall survival overall survival graph clearly showed a benefit even on dose reduction with ribociclib therapy, which was equal to or more than or 1 dose reduction. Next slide, please. So what about CNS metastasis? Can we use ribociclib in this group? Next slide, please. So patient with CNS metastasis, it was found that they had a longer time to progression, as seen in the clearly benefit from both the Kaplan survival curves, that patient who were treated with ribociclib had a more longer time to progression as compared to the other therapy. Next slide, please. So what if the patient has visceral metastasis and with aggressive disease? So next slide, please. So this is the evidence for patients with visceral metastasis and aggressive disease. It is a right choice study in which ribociclib was used with aromatase inhibitor, and the other arm was investigator choice of treatment, which was combination chemotherapy. Next slide, please. So in this study also, it was found that first line therapy with ribociclib and aromatase inhibitor achieved a substantial benefit over 1 year over combination with chemotherapy in aggressive disease, also clearly demonstrated in the Kaplan-Meier survival curve. Next slide, please. So overall response rate and time to response. So they were similar in both the ribociclib plus aromatase inhibitor as compared to the combination chemotherapy arm, as clearly seen in the bar diagram and also demonstrated in the right curve on the right side. Next slide, please. So what is my summary and conclusion? Ribociclib is the only CDK4/6 inhibitor to significantly improve overall survival across lines of therapy, irrespective of the menopausal status. Ribociclib also has demonstrated a significant consistent efficacy across patient subgroup, including high tumor burden with visceral metastasis. Only CDK4/6 inhibitor with proven twice PFS benefit with similar overall response rate and time to response versus combination chemotherapy in first line premenopausal patient with aggressive disease as per the right choice study. Only CDK4/6 inhibitor to be recommended by NCCN 2023 guidelines as first line preferred treatment. Only CDK4/6 inhibitor with a substantial benefit score as per the ESMO guidelines. The 3 CDK4/6 inhibitors are different due to their pharmacokinetic and pharmacodynamic profile, as ribociclib has higher CDK4 inhibition as compared to CDK6, and ribociclib also has a high free drug concentration, and it also has a potential impact on difference in efficacy and safety also. Next slide, please. So any questions? I would.
Thank you, Dr. Suresh. So, sir, in your practice, have you used which is your preferred drug, either to use ribociclib or abemaciclib in case of a CNS metastasis?
In my practice at our center, we usually have a MDT. If a patient has CNS metastasis, if it is symptomatic, then I do go for palliative brain RT first, followed by systemic therapy.
But if the patient is asymptomatic, sir?
Then in that case, still I may opt the option for radiation for the patient, as there is no much strong data regarding. But abemaciclib is a better drug if you go for CNS metastasis. But I do prefer to give the option of radiotherapy to my patient. In my practice.
Thank you. Thank you, sir. Thank you. So, shall we move on to next session?
Next session, I would like to invite to Dr. Piyush Mehta, sir, for
Thank
the
you.
raw session.
Yeah. So Abhimanyu, please run my slides. Okay. So this session is sponsored by Roche. So we'll be discussing the HER2 positive breast cancer and how we have transformed the journey of HER2 positive breast cancer patients. Next slide. Next slide. So Perjeta and Herceptin, which we know that pertuzumab and trastuzumab, that has transformed the treatment landscape, and that is the standard of care for patients with HER2 positive breast cancer. So in all three settings, either in the neoadjuvant, adjuvant, or in the first line MBC. So the pivotal studies for neoadjuvant settings in early breast cancer at high risk of recurrence. So we have a NeoSphere study. In this, the key finding was that addition of pertuzumab to trastuzumab and chemotherapy that significantly improved the breast PCR rate from 31% to 49% back compared with chemotherapy and trastuzumab alone. Then in the adjuvant setting, we have affinity study. In this, the addition of pertuzumab to trastuzumab and chemo that reduces the risk of recurrence or death by 23% compared with trastu and chemo and placebos. And patients with a not positive EBC, pertu, trastuzumab, and chemotherapy that reduces the risk of recurrence or death by 28% versus trastu plus chemo. And then in the metastatic setting, we have Cleopatra trial. In this, we know that addition of pertuzumab to trastuzumab and chemotherapy that significantly increases the median PFS from 12.4 months to 18.5 months. And the median OS that was also significantly increased in the pertu, trastu, and chemo arm, which is 56.5 months compared to 40 months in the another arm. So Perjeta and Herceptin and chemotherapy that is approved and recognized by most of the international guidelines as a standard of care for patients with HER2 positive breast cancer. Next slide. So HER2 positive patient with early breast cancer, the standard of care in neoadjuvant setting in adjuvant without any residual disease after surgery. So in neoadjuvant setting, like a patient with is newly diagnosed HER2 positive EBC, if it's T1, we can undergo with surgery. If it's not positive, we give pertu trastu based regimen for 18 cycles, and if it is not negative, we give trastu pecli for 18 cycles. And in tumor size more than 2 centimeter or not positive, we give chemotherapy with pertu and trastu, and then we do surgery. If there is a residual disease, then we give 14 cycles of TDM1. If the PCR is achieved, then we continue with pertu trastuzumab based regimen to complete 18 cycles. Next slide. So IV infusion of pertuzumab and trastuzumab that is well established, but they present challenges to patient and healthcare system because we know that they have a long infusion and observation time at and and congestion at hospitals and clinic. And pertuzumab is usually infused over 60 minutes followed by observation, and trastuzumab is usually infused over 30 to 90 minutes followed by observation for 2 to 6 hours. And so there is a challenge of improving the resources utilization, as the IV preparation time is longer than subcutaneous, and that require more associated resources. And then placement and the maintenance of indwelling venous excesses like either chemoport or PICC line. So we know the risk associated with these devices, like increased risk of infection, thrombosis, and discomfort. And challenge of venous excess in some patients, like either IV excess that can be particularly burdensome for patients with poor venous access. Next slide. So Phesgo, that is the first formulation in oncology, which has been in which it has to combine two monoclonal antibodies, pertuzumab and trastuzumab, in one vial for subcutaneous injection. And Phesgo that contain the same antibodies as approved for IV pertuzumab and trastuzumab, but it has a different route of administration, and it's formulated with RHU-PH20, which is a recombinant human hyaluronidase, to allow the subcutaneous administration of higher drug volume, which is 15 ml of the loading dose and 10 ml of the maintenance dose. It is ready to use fixed dose formulation administered by a subcutaneous injection in the thigh over 5 to 8 minutes. Next slide. So mechanism of action of pertu-trastu fixed dose combination for subcutaneous use. So pertu and trastuzumab combination for subcutaneous use that combines pertu and trastuzumab, both these are two monoclonal antibodies with recombinant human hyaluronidase, and pertuzumab that is designed to work with trastuzumab for dual HER2 blockage. And in preclinical models, pertuzumab targeted a different subdomain on the HER2 receptor than trastuzumab to block the dimerization with HER1 and HER3 receptors, and to provide a dual blockage of HER2 driver signaling pathways. And hyaluronidase, that is an endoglycosidase, which is used to increase the dispersion and absorption of co-administered drugs when administered subcutaneously, and that allows subcutaneous delivery of larger drug volume, and it increases the permeability of subcutaneous tissue by depolymerizing hyaluronidase. And the effect of hyaluronidase, they are reversible, and the permeability of the subcutaneous tissue that is restored to normal within 24 to 48 hours. Next slide. So impact of recombinant human hyaluronidase on the subcutaneous injection of large fluid volume. The subcutaneous layer that contain a matrix of hyaluron fiber, collagen fiber, which limits the subcutaneous administration of volumes to less than 1 ml. So the addition of RHU-PH20 to Phesgo that temporarily and locally degrades the hyaluron at the injection site with no change in the structure, providing macromolecules like collagen and elastin. And this degradation that results in temporary increase in the local subcutaneous dispersion area, enabling large volume of fluid to be administered. And so after subcutaneous administration, the architecture of the skin is reformed within 1 to 2 days due to rapid clearance of recombinant hyaluronidase and fast hyaluron turnover. And so this allows subcutaneous administration of larger volumes than 1 ml. So we know the bolus is of 15 and then maintenance is of 10 ml. Next slide. So this allows bolus injection of 10 ml. So before infusion and immediately post infusion, we can see without the use of this hyaluron. But with 2000 unit per ml, if we can see before infusion and after infusion, then we can easily make out the difference that there is no swelling apparently visible. Next slide. So does Phesgo, the FDC, this pertuzumab, trastuzumab, this subcutaneous, they have the same pharmacokinetics and other efficacy safety as the pertuzumab plus trastuzumab in IV formulation. Next slide. So Phesgo clinical development program. So the finding and confirming the dose of pertuzumab within Phesgo. So it was a phase 1B in HMV and in early breast cancer that was completed in May 2018. And the recommended doses for loading dose, it's 1200 milligram of pertuzumab and 600 milligram of trastuzumab. And Phesgo maintenance dose is 600 milligram of pertuzumab and 600 milligram of the trastuzumab. And PK for pharmacokinetic efficacy safety. So this is a Derica study. It was a phase 3. It's ongoing study. And another study in phase 2, that is the primary analysis was done, and it was presented in ESMO 2020. Next slide. Phase 1B dose finding study was used to select the dose of pertuzumab and for Phesgo. So in part 1, there were healthy male volunteers in cohort 1, cohort 2. So different dosage schedule in like pertuzumab IV 420, subcutaneous 400. In another cohort, subcutaneous 600. In another 1200. So different dose combination of pertuzumab and trastuzumab was used, and target subcutaneous dose determined. If yes, then in part 2, patients with EBC, they are enrolled, and pertuzumab subcutaneous target dose with Herceptin, or in cohort B, pertuzumab subcutaneous dose with Herceptin subcutaneous 600 milligram, and in cohort C, pertuzumab target dose with trastuzumab 600 milligram subcutaneous formulation. And if the target dose has not been determined, then the additional cohorts, if pertuzumab exposure different from the target concentration desired, or if the pharmacokinetic variability is too high to determine the dose. Next slide. So PK and dose findings. So in BO 30185 study, that selected a loading dose of 1200 milligram of pertuzumab subcutaneous and a maintenance dose of 600 milligram pertuzumab subcutaneous to be used in Phesgo, and PK data in healthy male volunteers and patients with early breast cancer that predicted that these doses will result in an equivalent pertuzumab serum exposure to that of Perjeta IV 840 and 420 milligram respectively. And the dose finding processes used to find the subcutaneous dose of pertuzumab, they were similar to those used successfully in the development of both Herceptin in subcutaneous and in MabThera subcutaneous. And there are no new safety signals observed for pertuzumab subcutaneous alone, or when it is co-formulated with trastuzumab subcutaneous. So the pharmacokinetic and the safety results of BO 30185, they supported further development of Phesgo. Next slide. So Derica study, it's a phase 3 non-inferiority study assessing the pharmacokinetics and the efficacy and safety of pertuzumab, trastuzumab fixed dose combination in subcutaneous versus Pertu plus Trastu in IV. So patients with centrally confirmed operable or locally advanced or inflammatory or HER2 positive breast cancer, they were enrolled. Total of 500 patients were enrolled in this study. And in arm A, which was investigated dose dense AC every 2 weekly for 4 cycles or 3 weekly for 4 cycles, followed by pertuzumab plus trastuzumab IV for 4 dosages. And in this similar docetaxel or paclitaxel and patient surgery was done. And in the another arm, similar drug was used, like a dose dense AC, either 2 weekly or 3 weekly regimen, followed by the pertuzumab and trastuzumab fixed dose combination subcutaneously, either with paclitaxel or with docetaxel every 3 weekly surgery. And then after it was pertuzumab, trastuzumab was continued for a total of 42 weeks in both the arms, and then follow. So the stratification factors, they were hormone receptor status, the clinical stage at presentation, either stage 2, 3, 3B or 3C, and the type of chemotherapy used, and the primary endpoint being non-inferiority of cycle 7, and the concentration of pertuzumab at the trough, and the key secondary endpoints being non-inferiority of the cycle 7, pre-dose cycle 8 trastuzumab serum trough concentration, and the PCR, and the safety, IDFS, EFS, and the overall survival. Next slide. So pharmacokinetic parameters, they are important for understanding the bioequivalence between IV and subcutaneous formulations. So pharmacokinetic endpoints, they are a key focus of per2/2 fixed dose combination subcutaneous clinical development program, and they are used to assess bioequivalence. So in this, we can see the concentration at trough plasma by serum drug concentration at the end of a dosing interval, and that is related to the mode of action, and it is associated with the clinical outcome. And then we have an area under curve which provides information over the course of treatment cycle, that how much of a drug that stays in the body and for how long, and that may correlate with the concentration at trough. And Cmax is a maximum or peak concentration or maximum serum drug concentration. So Cmax after IV, that is not subject to distribution and elimination effects compared to Cmax after subcutaneous, because it required time for absorption, and that is subject to elimination before reaching the bloodstream. And so it's not clearly related with the clinical outcome. And we can see through the graph that how concentration, it's at the time 0, it's maximum in the IV formulation, but with subcutaneous, as we know, that it will take some time to get absorbed and to come into the circulation. But at the Cmax, this is the trough concentration, which is associated with clinical outcome, that remains almost similar. Next slide. So we can see that the primary endpoint, which is a serum concentration of pertuzumab at trough, so that remains almost similar. And so the lower limit of the 90% confidence interval for pertuzumab serum trough concentration and trastuzumab concentration, that exceeded the non-inferiority margin of 0.8. Next slide. So safety profile of pertuzumab, trastuzumab fixed dose, that was comparable to the IV formulation. Any grade adverse event, they were almost comparable in both the arms, and more than or equal to grade 3, they were more slightly a bit more in the IV compared to those in the subcutaneous. And one death was reported in both the arms, and the death was unknown to the HER2-related treatment, and it was because of urinary tract infection in both these cases. And the treatment was discontinued because of adverse event in 10% of patients compared to 7% in the subcutaneous arm. And so the rate of treatment discontinuation, they were almost similar. Next slide. So the most common adverse event, they were balanced between the treatment arms. So like the most common being the alopecia, nausea, diarrhea, anemia, and asthenia. But we can see that if you see compare the diarrhea, that is almost comparable between other. And if we see the comparison between the subcutaneous and IV, so the side effect profile, that is almost similar. Next slide. So, and the incidence of adverse event of interest, including cardiac dysfunction, infusion-related reaction, hypersensitivity, that was comparable between the treatment arms. So diarrhea, that was almost similar in subcutaneous as well as in the IV formulation. Similar is the risk of neutropenia, cardiac dysfunction, and infusion-related reaction, anaphylaxis, mucositis, ILD, or any serious skin or rash or any skin reaction. And next slide. And there was no meaningful difference in cardiac safety between the treatment arms. We can easily see that in primary cardiac event and significant decline in ejection fraction, that was almost similar. And ejection fraction decline if you see the secondary cardiac event, which is by initial LVEF assessment, they were slightly a bit more in the IV than in the subcutaneous formulation. Next slide. So pertuzumab, trastuzumab fixed dose combination subcutaneous administration, that showed non-inferior pharmacokinetics versus pertuzumab and trastuzumab IV with comparable efficacy, safety. And pertuzumab trastu fixed dose combination, that was non-inferior to pertu trastu IV based upon the cycle 7, which is pre-cycle 8 pertu trastu serum trough concentration, and the PCR rate, the pathological complete response rate, that was nearly identical to the pertuzumab trastuzumab IV combination of around 60%, and that was consistent with the data from other trials of pertu-trastu IV chemotherapy. And the safety profile of pertu-trastu fixed dose combination subcutaneous, that was comparable to that of pertu-trastu IV, and that was consistent with previous studies of pertu-trastu IV with chemotherapy, and no new safety signals were identified, including when switching the formulations. So do patients prefer subcutaneous to IV formulation? Definitely. Next slide. So it was of patients with HER2 positive EBC who have completed neoadjuvant pertu-trastu and chemotherapy, and a crossover was done, and the pertu with trastu IV for 3 cycles, and then they were crossover to subcutaneous.
Conclude your talk, please.
Yeah, I'm concluding in 2 minutes. And then in the another arm, they were vice versa. And if we see the patient treatment continuation period, patient selected and for a total of 18 cycles in the neoadjuvant setting, and they were followed. And the primary objective being the patient preference of subcutaneous formulation. Next slide. So preference for this subcutaneous was very and fairly strong for the majority of patients. And the main reasons for subcutaneous preference is being the less time in clinic, more comfortable during administration. So 87% they choose fixed dose combination compared to the IV formulation. Next slide. So most of the patients, they were very satisfied with subcutaneous compared to IV formulation, and the treatment had no impact on patient and healthcare physician speaking time, and most patients, they had more enough time to talk with their physician during treatment. Next slide. Majority of the healthcare professionals, they feel the switching from IV to subcutaneous would save the time and resources, as we know that it will decrease the total drug preparation time from 20 minutes to 5 minutes, and in the treatment room it will decrease it from around 2 to 3 hours to around 30 minutes. And so most of the physicians, they thought that this combination, that was the quickest form from start to preparation to completion of administration, and less resource utilization. And so that resulted, and this also resulted in very less drug wastage. Next slide. So the adverse event before and after switching, they were also similar with no new safety signals identified. Next slide. So patient satisfaction, more patients were satisfied or very satisfied with this combination. And most of the patients, they indicated that treatment had no impact on the time they had to talk to the nurse or doctor. And the healthcare professionals indicated that this combination had marked time savings and required fewer resources. And this was generally well tolerated, and with safety profile in lining with the previous studies, no new safety signals were observed, and safety results, they support those seen with fixed dose combination in the Fidelica study. Next slide. So practical considerations in real world. Next slide. Is just to ask the patient to sit back in a reclining chair and to make the thigh area accessible, to make sure that we sit on the chair at a right level so the feet are flat on the floor, and you are able to sit without twisting, bending, or reaching to administer the injection, and ensure that the head are in good position resting, and this will reduce any unnecessary movement. And the injection site that should be alternated between the right and left thigh, never administered in the abdomen, and to do not split the dose between 2 syringes or between the 2 sites of administration. And even with very slim patients, pertu-trastu fixed dose combination use is safe and comfortable, and each new injection should be given at least 1 inch from the previous site, and an healthy area of skin which is not red, bruised, tattooed should be used, and record the used site to the patient note. Next. So it's just an administration, how to administer the injection. And for the loading dose, it took around 8 minutes for administration, and for observation of 30 minutes. And in maintenance, it took 5 minutes, and for a 15-minute observation. And we have to maintain the needle at an angle of 30 degrees. So that injection that can feel difficult because of the thickness of the solution. So using a butterfly needle, that makes administration easier. and keep the needle in place and just make sure that the needle is at right 30 degrees at the angle. And the injection should be paused if patient experienced any injection related reaction, and the injection that should be discontinued immediately if the patient experiences a serious hypersensitivity, and to make sure that medication to treat reactions are available. And after loading dose, patient has to be observed for 30 minutes, and for maintenance dose after 15 minutes. Next slide. So depending upon the hospital settings, it can be administered on a dedicated date, having a single room for administration and observation that give patient enough physical privacy, but also enable them to talk to more freely about their challenges. And next slide. Next slide. So as discussed, it reduces the drug administration time, lesser observation time, less invasion, and fixed dose formulation, less drug wastage, increase availability of staff for other tasks, reduced time required for drug preparation and administration, and to no new safety signals they were identified when switching from IV to Phesgo and vice versa. Next slide. So it's a last slide, and it's a first formulation with 2 antibodies. Phesgo has a cycle 7, pre-dose cycle 8 concentration they were determined, and the PCR rate they were identical between the IV and the subcutaneous in ITT population, and they were not impacted by the BMI. Next slide. Majority of the patients, they prefer, definitely as discussed, subcutaneous formulation. It's now FDA and EMA approved for these indications in HER2 positive EBC, MBC with or without concomitant IV chemotherapy. Next slide. Thank you. So this concludes my session.
Thank you, sir.
Thank you.
So, Piyush, sir, please invite the next. Yeah.
Just a second. For the next discussion, I would like to invite Dr. Burhan Mani. Sir is a senior medical oncologist at AOI Jalandhar. So welcome, sir, and thank you for this, for agreeing to this talk. Sir will be moderating a session on a case-based panel discussion on HER2 positive breast cancer. Over to you, sir.
Thank you, Piyush. Thank you for inviting me for today's CME. And I think you have already said for me, you have set the background for discussing the case-based presentation. So can I share the slides?
Yes, sir, you can share.
Okay. So I would like to have my panelists for starting this discussion. And I think I will start with Dr. Moeen.
Yes, sir.
Yeah. Dr. Kanika.
Hi, sir.
Yeah. Dr. Mukesh Bansal.
Hello, sir.
Dr. Sonia. Dr. Sonia is over there. Okay. And Dr. Narayan.
Yes, sir.
Good evening to all. And today we'll be having a case-based discussion. So it is on HER2 positive breast cancer. So it will be a more of a more of a discussion purposes. So how we are dealing in our day-to-day clinical practice, how we see these patients, and what are our goals as far as management of these patients is concerned. So to start with, we have a case. She was a 72-year-old female postmenopausal with no comorbidities or family history. She presented to breast clinic with a growing mass in the left breast, which was first noticed 3 months back. And over the last 2 weeks, the mass had become painful to touch. And on examination, it was a 3 centimeter mildly tender mass, which was palpated in the left breast with periareolar skin thickening. Now, the patient journey. So before starting further on the deliberation on this case, I would like to get a brief background about how we are seeing in the clinical practice, what is actually the load of patients that we see, and especially, so I will start with Dr. Moveen. Dr. Moveen, I would like to know from you that what is your percentage of patients of early breast cancer that come to your clinical practice?
So very few patients actually are used to come with the early breast cancer, approximately 10 to 15%.
Okay. And any reasons for not having very early not much of percentage
early
of
breast cancer, early breast cancer, which I usually get from the surgeons only. To my OPD, directly to my OPD, only the metastatic or the late breast cancer patient used to come to my OPD.
Okay.
Which I referral from the surgeons is early breast cancers.
Okay. Dr. Kanika, do you routinely perform any genetic testing in this in your setup?
So, not all the patients, but yeah, if the patient is young, less than 50 or a triple negative or who have a history of breast cancer, then yes, we are performing in all those patients. But
Okay.
yeah, 72
But not
with a
in all
strong
patients.
ERPR positive, we are not doing it.
So what are your views on the screening? Because we, as Dr. Moveen told, that we don't have many patients in our practice, this early breast cancer. So what is your view on having the screening? Are we still lacking in the screening, and how you are seeing the screening for the breast cancer in our population? Is it a time to start it right now, or how you look at this? Dr. Kanika.
So I'm basically a big advocate for breast cancer screening, since it's a preventable disease and it's with a almost 95% of cure rate if is detected in stage 1 and 2. So I counsel all my patients and their relatives for self breast examination, mammography after 40 years of age, and many of my patients, contrary to Dr. Moveen, they are coming in early stage that they have self-diagnosed by doing a breast examination and via mammography also. So it is actually a very useful tool for breast cancer.
Okay. So, Dr. Mukesh, I just want to know from you, how will you define high-risk patients of breast cancer?
I think, sir, any patient with HER2 positive disease or triple negative breast cancer, I think they are high risk. Even if the patient is ER hormone positive, sometimes low ER positive with high Ki67 or with clinical presentation which is not accordingly hormone positive, I also treat them as high risk in breast cancer.
Okay. So, Dr. Sonia is over there.
So I think Madam is she will join.
Okay, no issues. Dr. Narayanan, how will you? What is your take on having a pathological complete response as a surrogate marker for survival?
Yes, definitely. Pathological complete response is surrogate marker for survival in case of HER2 positive breast cancer and triple negative breast cancer. But it is not the surrogate for survival in case of ERPR positive and HER2 negative breast cancer. So in case of TNBCs and HER2 positive, yes, sir, it has shown studies and combined pooled analysis has shown that achieving the PCR rates have given us the better survival outcome. So in those two situations, HER2 positive and TNBC, we can say PCR are surrogates and markers for survival endpoints.
And what is your clinical practice? Do you actually give neoadjuvant therapy for all of your patients who are, as you mentioned, about HER2 positive or TNBC?
Yes, sir. Yes, sir. If it is HER2 positive and TNBCs, we generally prefer neoadjuvant chemotherapy plus targeted therapy in case of HER2 positive. But sometimes in exceptional cases, like if the primary is very small, like less than 1 centimeter, and it is then in that exceptional scenarios, it may be considered direct surgery. But otherwise, generally more than 1 centimeter or 2 centimeters, we generally prefer giving neoadjuvant in case of HER2 positive and TNBCs.
So I think all of us seeing our in our clinical practice, we have these patients, and as you have already pointed out, the various challenges that we are facing. Now, coming to this particular case, so a mammography was ordered, which showed there was a 3 centimeter mass in the left upper outer quadrant of the left breast with periareolar skin thickening with left axillary nodes. And it was a Birides 5 lesion. Then in the right breast, there were also a lesion, but Birides 4A. A USG guided bilateral breast biopsy was done, which showed in the left breast, it was a infiltrating ductal carcinoma, ERPR negative, HER2/3 positive, via Ki67 of 25%, and right breast, there was no disease. A metastatic workup was ordered with the form PET-CT, which showed there was a left breast, left axillary, and left supraclavicular lymph nodes were positive. Right breast, again a small lesion, but and the right, there was a axillary nodes, they were reactive, very long nodules. 2D echo was done, which showed there was a LV ejection fraction of 20%, and then other markers as well were done. So although they have mentioned here that the stage was 2B, but I don't, although these slides are provided by Roche, so I would like to have Dr. Moveen over here. So how you stage this patient now after the PET-CT and the further investigations are there?
Sir, as the node is positive and lesion is approximately 3 centimeter, lung nodules are in doubt. They are not FNAC or no biopsy was done from the lung nodules. Neither it's mentioned whether they are we are able to get the FNAC or biopsy from the lung nodules. So it's a T2N1. Then we can have.
So what about Dr. Moveen? What about left supraclavicular nodes? They were on the. So does it qualify for an N3 disease?
Yeah, definitely N3. That is left supraclavicular nodes are histopathologically proven.
No, it was that's why what I'm saying. It was a PET-AVID. It was a PET-AVID disease on the same side of the breast.
I will go for FNAC and prove it whether it's positive or not. If it is positive, then definitely it's an N3 disease.
Yes, yes. So overall, it was we can say that if it is a left supraclavicular was positive on the cytology as well, so then it qualifies for a locally advanced disease. So now coming to the how to treat this patient. So I would like to have Dr. Kanika, our deliberation. So how will you treat this patient?
So since it's a locally advanced disease, we can give the benefit of doubt to the patient and not include that metastatic disease, those lung nodules. But again, the multiple factors, since she don't have any comorbidity, but considering 72 years age, I will still be hesitant to use TCHP regime. So maybe a weekly paclitaxel along with a dual HER2 blockade for
her. Dr. Mukesh?
Yes, sir. As it is a locally advanced disease, as Dr. Kanika rightly said, we will give the benefit of doubt to the patient regarding the lung nodules. So I will start with the neoadjuvant treatment. If there are no financial constraints, I will like to go with the dual HER2 blockade. Regarding the chemotherapy partner, I will prefer to give TCHP since it is a neoadjuvant setting and we are in a curative setting. But if the performance status is not good or comorbidities are there, or if the patient tolerates the chemotherapy poorly, then I will shift. I can shift the patient to taxane plus dual HER2 blockade only.
Okay, Dr. Narayanan, your take on this? What the other panelists had.
Yes, sir. I totally agree with your opinion. And looking only as per the age, we cannot decide. But after looking at the performance status of the patient, yes, if it's PS1 and everything looks good, then we may as well start with dual auto blockade plus TCHP regimen. Otherwise, if there is little doubt, then yeah, triple drug to dual auto blockade and one taxane. That would be preferable, as ma'am said.
And Dr. Moveen, you are concur with the other panelists about this?
Definitely, depending on the performance status of the patient and the considering the comorbidities, do a HER2 blockade and along with single agent taxane.
Okay. So I think all of them agree with the having a neoadjuvant treatment. That is the first thing. And then having a dual anti-HER2 blockage as well. The chemotherapy choice will definitely depend upon the multiple factors, which includes the performance and the other comorbidities of the patient. So the patient was explained about the outcome prognosis and the advised neoadjuvant chemotherapy along with the anti-HER2 therapy. She was started on TCHP-based therapy, and the dual targeted therapy was administered in the form of Phesgo as a subcutaneous preparation. So after 3 cycles, repeat PET was done, which showed there was a complete response in the nodal lesions and a mild uptake that was persisted in the left breast lesion. Then 3 more cycles were given, and after that repeat PET was done, and a complete metabolic response was seen. And the patient was advised to go for surgery followed by radiation and anti-HER2 therapy. So this was the PET-CT that was seen. So we can see here, initially after the interim PET, there was some disease. Then later, once she was given the 6 cycles, then she was again reassessed with PET-CT, and there was a complete metabolic response.
What happened to the lung nodules? They reduced?
Yeah,
or they
lung
decreased?
nodules, they persisted with the same. There was not change in their size or in their activity, metabolic activity. So I would like to have from Dr. Kanika you that how many cycles of neoadjuvant treatment do you prefer in your patients before they're subjecting from the surgery?
So, based on the tolerance, 4 to 6 cycles of neoadjuvant chemotherapy. If they're tolerating well, I like to complete all the 6 cycles upfront. And if, even with the dual blockade and this, the incidence of diarrhea is very high in the patient. So if they are having, frequent delays because of neutropenia or the side effect, then, and the response is there. So I would like to get a surgery after 4 cycles also, 4 to 5 cycles, and then continue with the targeted only.
Any difference in opinion from other panelists, or they have the same?
I agree with Dr. Kanika. I think if the patient is tolerating, then I will like to complete all the 6 cycles. Otherwise, we can go for surgery after 3 to 4 cycles.
Great. So I think Dr. Piyush has already covered about the role of dual anti-HER2 therapy across the indications, whether it is neoadjuvant, adjuvant, or the metastatic setting. And when we know that dual anti-HER2 therapy along with chemotherapy, it is already approved and it is recognized across the various guidelines as a standard of care for patients with HER2 positive breast cancer. And this is the same thing we had already mentioned about the achieving the what our aim is to achieve a pathological complete response, because it provides us the surrogate marker for the survival in these patients. So this is the same NCCN guidelines, the same Gallian International guidelines, then the AGO recommendations for having the dual anti-HER2 therapy along with the chemotherapy as a neoadjuvant setting in HER2 positive breast cancers. So this is the same thing actually what we have discussed about having. So now I would like to have some more questions from the panelists, that especially what they will like to give in adjuvant setting in this patient. So starting with Dr. Moveen. So how will you proceed for adjuvant therapy in this patient?
Depending on the histopathological report after surgery, whether the patient have attained PCR or not. If the patient have not attained PCR, means microinvasive metastasis is there, and then we will go with the TDM1. And then if the patient have attained PCR and all margins are negative, then we can go with the trastuzumab adjuvant for 17 to 18 sitting 3 weekly.
Okay. Dr. Kanika, what is your, if the patient now, if the patient has received neoadjuvant setting, the dual, what are your consideration for continuing the dual anti-HER2 therapy as a maintenance in these patients who have achieved the pathological complete response? Do you give in all your patients who have achieved pathological complete response, or you stratify?
No, actually, if they have achieved PCR, so I just continue with trastuzumab alone in the adjuvant setting, actually.
Any subset of patients where you will continue to have the dual anti-HER2 blockage as
so like if the patient initially have a high disease burden, like if this patient and I'm not giving the proper chemotherapy in those subgroup, either a single agent paclitaxel or a weekly, and just omitting at 3 to 4 cycles, Then to cover, have a proper coverage, then I continue with the dual blockade in the adjuvant setting also. But if the patient have tolerated the chemotherapy well and having a PCR, then just trastuzumab in the adjuvant setting.
Dr. Narayanan, your take, if the patients have node positive disease at the outset, do you like to continue or do the single, or do you continue have to have dual anti-HER2 therapy?
As ma'am said, in this case, there was only one N1 disease. So after we have achieved PCR, yeah, probably we can continue with single or two blockade with trastuzumab. But if it would have been like N2 disease or larger disease size, higher grade disease, then definitely I would prefer dual blockades.
Dr. Mukesh, your any take on having any unaddressed challenges with regard to the adjuvant therapy setting in these sort of patients?
I think, sir, unaddressed challenges basically are if there can be a better marker where we can better stratify where to continue for the dual anti-HER2 targeted and where to shift to trastuzumab only. As of now, my practice is usually to shift to trastuzumab alone if PCR is achieved, or if it is not achieved, then shifting to TDM1. But these can be unaddressed challenges where we can better stratify where we have to go for dual anti-HER2 therapy in the adjuvant setting.
I think all the panelists, Dr. Kanika and other people, as they were mentioning, that probably, yes, if we see the affinity data, there was not much of a benefit in continuing if you see as a complete population. But definitely if you see the subset population, if the patient had node positive disease, especially 4 or more nodes were positive, then as the number of nodes where positivity was high, the benefit of continuing the dual anti-HER2 therapy definitely had a benefit as far as the survival was concerned. So I think one important thing we can take from here is that we cannot see all the patients continue with the dual anti-HER2 therapy because it adds to the cost. So you have to stratify based on their risk profile and especially the nodal burden of the disease that they had at the outset. I think one more thing is Dr. Piyush already presented a very nice presentation on the Phesgo. We know that now we have a fixed dose combination of dual anti-HER2 therapy that is available. It can be administered as a subcutaneous injection and every 3 weekly. And it is available in the form of a loading dose of 1200 milligrams of pertuzumab with 600 of trastuzumab and maintenance of 600 pertuzumab with 600 of the trastuzumab. And it has been already presented by Dr. Bhuvish. So I would like to know from panelists how has been their experience with use of Phesgo in HER2 positive patients. So starting with Dr. Moveen, how has been your experience, and do you face any sort of challenges for Phesgo in your patients?
Sir, truly speaking, I have not used Phesgo till date. I have only 2 to 3 patients who are HER2 positive, and I am using trastuzumab and pertuzumab IV preparations only. And this
any reason for not switching your, or do you continue?
Because we have not trained such staff who can use, and the second thing is a cost issue. Cost issue is a big factor, and dual HER2 blockage is very less. Few patients of HER2 positive are getting the dual HER2 blockage.
Okay. Dr. Kanika, your experience and the challenges that you face.
So not much challenges with the Phesgo, just the financial constraint if the patient is having. But with the neoadjuvant setting, it's actually pretty reasonable because it increases the PCR rate and patient have to buy only 3 doses. So the cost effectiveness is very good. As far as the administration goes, one patient initially, complained of the what do you call redness at that site, but it also subsided after 2 days. Other than that, there was no any local side effect or anything. So it's a good drug actually.
So you are more sort of using the Phesgo sub.
So I have shifted to Phesgo. I think only one patient is receiving IV pertuzumab, but otherwise all of them either in the metastatic or neoadjuvant they are receiving Phesgo only.
Okay. Dr. Mukesh, your experience of using Phesgo?
Sir, I have also shifted my patients to Phesgo, and I think the experience is good. It is convenient for the patient, quick, and no major challenges apart from where the patient is of very much lower BMI or obese patient. Although the trials show the pharmacokinetics and all that doesn't make a bigger difference, there I have some doubts left, especially in the neoadjuvant setting. Otherwise, I think it's a wonderful drug, convenient for the patient, and I am not facing any major challenges. And is cost effective also, I think, with the PAP the company is providing compared to the IV pertuzumab and trastuzumab.
So have you used in neoadjuvant setting or in the metastatic setting, this Phesgo?
Sir, I have used in both neoadjuvant and metastatic settings.
And how has been the responses to these Phesgo?
The responses were wonderful. The patient, I have not used in many patients, so say of much, but in the 1 or 2 patient in both the settings I have used, I have got a good response. In neoadjuvant setting, the patient achieved PCR.
Dr. Narayanan, your experience about Phesgo?
Yes, sir. I've also not used in many patients, only 1 or 2 patients we had used, and it's very convenient, and patients also, they seem happy. It's not time consuming, and it doesn't seem like taking chemotherapy, long duration infusion. So it's the experience is good, and I expect to use it more and more in future days.
I think Dr. Piyush also mentioned in his talk, there was a lot of acceptability as far as the patient was concerned, and definitely as far as the outcome was concerned, it was comparable with the IV formulations. So this is already the data what he has shown about the non-inferiority data of pharmacokinetics of IV versus the subcutaneous preparation. So one important thing is that now we have this Phesgo available. Do we need to switch from the patients who are already on maintenance of pertuzumab, like patients are metastatic patients? Because Roche does allow the patients who are on pertuzumab as a maintenance, they can be shifted to Phesgo. So have you done in any of your patient, Dr. Moveen?
So definitely we will shift. And if we get any patient of a neoadjuvant setting or metastatic setting, and when we get a chance to use the dual HER2 blockage and cost will not be an issue, then definitely we will shift to the Phesgo.
Yeah, Dr. Kanika, have you done any of your patients who have been on IV and you have shifted to subcutaneous formulation?
No, actually, if the patient asks for it, then maybe, but if they are responding to one regimen, I don't want to shift to the other. So from the upfront, I can go with the Phesgo now for all the patients, but who are already on pertuzumab, I'm continuing with them also. IV preparation, actually.
Okay. Dr. Mukesh?
Same, sir. I have not shifted, but from the upfront, I have given in 2 or 3 patients.
Okay. Dr. Narayanan, you have a patient?
Not shifted yet, but yeah, from first cycle we had started.
Great. So one more point that was raised by Dr. Moveen was about the cost thing. We know that one thing that has helped our patient is that with the assistance that are provided by the Roche, that it is almost 30% cheaper than the IV pertuzumab, and it also offers us giving her the innovator Herceptin as well. So will it have any effect in the enabling the patients getting the dual anti-HER2 therapy now more? It makes them more accessible for this combination, Dr. Moveen?
Sir, definitely for sir, in our practice, in our conditions, cost is a biggest factor for the HER2 positive patients. Then definitely if the patient is ECHS patient, TPA patient, then definitely Phesgo is, we are using upfront dual HER2 blockage, and Phesgo will a wonderful molecule. But when there is a cash patient has to purchase these molecules from his pocket, then definitely we will think of trastuzumab, which of the lower cost, which patient can afford, and then patient will think of these things. And HER2 dual blockage is not accessible and not possible in every case.
Dr. Kanika, how you have changed your practice now? Do you are more focusing, you can say, putting asking them to go for Phesgo because you know that you are going to have the pathological complete response is your surrogate marker for survival. So how you counsel your patients for the Phesgo?
Basically, I just counsel them the whole treatment plan upfront, because if they are not achieving PCR, then again we have to counsel them for TDM1. That is also not a
Yes.
very cheap molecule. So if we
Hmm.
see the overall cost, that is actually even more if they don't achieve PCR. And with this, they just have to buy the three, doses, and the rest three are free. So it is actually cost effective, and thankfully with the dual blockade, I have yet to see a patient who have not achieved PCR in those patients. So I counsel them, but yeah, if they are not financially well, so I don't push them for a dual, and we will see. And most of the patients who don't achieve PCR, we are actually in those also we are continuing trastuzumab only. So if they don't, so we don't follow this protocol also. So we go with TCH and then give trastuzumab as maintenance only in those
Yeah.
patients.
I think
Sir,
definitely.
sorry to disturb. Kindly
Yeah.
conclude, please.
Yeah, just. So I think it has already been, we have already have all these guidelines, and now it has also been, it can be substituted from IV, we can give the patient to the subcutaneous form. It has already been approved. So to conclude, I would like to say that Phesgo, it offers tested efficacy, and it is recommended by the various guidelines. It has a convenience and the quality assurances that it provides. With the cost reduction, it saves the time for the daycare staff and the patients, and ultimately it reaches to achieve the desired patient experience. So I thank all the panelists and the organizers for the event today. So over to the organizers.
Thank you.
Thank you.
Thank you, Dr.
Thank you.
Thank you, Dr. Kanika. Thank you, Dr. Narayan. So moving on to the next session, which is a panel discussion. So I would like to invite Dr. Gurvinder. Hello, sir. Good evening.
Hi,
Thank you, sir, for this.
Hi.
Yeah. So we know that sir is a consultant, a medical oncologist at CCA, Ludhiana. Sir will be discussing on ovarian malignancy, a panel discussion. Over to you, sir.
Thank you, Bish. So, good evening, everyone. And thank you, Dr. Piyush and all organizing committee. So, we'll be discussing the management of advanced ovarian cancer. So, I'd like to invite my panelist, Dr. Navdeep.
Hello, Dr. Gurvinder.
Dr. Priyanshu Chaudhary. Hello. Dr. Pradeep
sir, good
Patil
evening.
and Dr. Kiran. Hi, Dr. Piyush. So everyone is
Kindly make it
here.
full screen.
Give me a minute.
सर जो एक ये नीचे ना कंप्यूटर जैसा आइकन बना है, बुक, ये इधर राइट साइड में इस पे क्लिक कीजिए, ये राइट वाला सर.
No. Yeah. So we'll be discussing shortly what we are daily doing in our practice. A 56-year-old female presented with abdominal distension. She was investigated and diagnosed with a high-grade serous ovarian carcinoma. Her CT thorax abdomen pelvis was done, which is suggestive of right adnexal solid cystic mass lesion of around 11 into 10 centimeter with bilateral iliac nodes, 2 into 2 centimeter mental deposits, and moderate ascites. So this is her CT picture. ECOG performance status 2, ascites, pelvic mass, serum albumin 2.7, multiple peritoneal deposits, mental liver surface deposits, quite a huge burden of disease. CA 125 is quite high. CA 1.29 and CA 19.9 mildly slightly raised. Dr. Priyanshu?
Yes, sir.
So, what is your take? Like, how do you proceed? High-grade serous ovarian carcinoma, stage 3C, clinically.
So in this case, I mean, in ovarian malignancies, the surgeon is the king. So first of all, I discussed with the surgeon. In this case, it looks, with moderate ascites and, large deposits. So it looks like an unresectable. So in this case, I would, if symptomatic, would go for a therapeutic as well as diagnostic ascitic tap. And if that is negative, then definitely biopsy from the adnexal mass.
Biopsy already done, mental.
Okay. So definitely then NSCT. It looks like an NSCT, but I'll have a discussion with the surgeon. Definitely.
Yeah, definitely we'd like to have a discussion with the surgeon because anyhow they have to resect it. We are not going to do the surgery. And it looks like that upfront primary cytoreduction is not feasible. So definitely NSCT, neoadjuvant chemotherapy is unlikely. Bulky upper abdominal disease and portal mets, then omental deposits, and stage 4 definitely we don't go for primary cytoreduction, and where we are anticipating that there will be bowel resection and stoma need is high. Multiple trials we already know that has been done comparing neoadjuvant chemotherapy to primary debulking surgery, and overall survival same, but yeah, the rate of R0s were higher in neoadjuvant and the need of stoma was less in neoadjuvant. Dr. Kiran, what drugs you will choose for neoadjuvant in this case, and what will be the schedule? Weekly versus 3 weekly, and what drugs?
As she's a young lady, and you have stated as you told, the performance status is good. So I would like to go with the paclitaxel with carboplatin, and I will prefer the 3 weekly schedule. So also we will
And genetic
and also we'll discuss with the relatives regarding the role of bevacizumab because she has upfront ascites, omental nodules. So stage 3, stage 4, the bevacizumab is always better. But we have to see the cost issues and the cost constraint. And the genetic testing, yes, sir. Upfront, every patient we are doing now BRCA testing, BRCA germline testing. And if BRCA is negative, then I would like to go with
in all
testing. Hello, am I audible?
Dr. Priyank? Yeah, Dr. Kiran.
Yeah.
Hello.
Hello.
Yes, Dr. Kiran.
Yeah, so I would go like to do with the germline BRCA testing. If that's negative, then the definitely HRR testing.
So, germline or cancer, any histology?
Govinda sir, I think your bandwidth is very low. If you permit, we can share your slide on behalf of you.
Yeah, please share it.
Thank you. Just do a stop sharing, please. So click on stop sharing.
Sir, hope my slides are visible.
Yes.
Yes.
ठीक है.
Hello.
When you go to the next slide.
Next, it is genetic testing. So all patients stage 3, you will advise for bevacizumab.
If the cost is not issue, and definitely if the ascites, I would like I always prefer to use bevacizumab.
Okay.
But
Why
the
not post IDS? The patients who are having like R2 resection or stage 4, definitely yes, but in stage 3, why not post IDS who have a R2 resection?
Yeah, that's correct. But the main issue with the bevacizumab, that's a cooling period. So most of times I will give the bevacizumab in cycle 1 and cycle 2, and then 3/4 we will skip. So in between, after the third cycle, we are doing reassessment, and according to that surgery, we will discuss again with the surgeon it is resectable or not.
Okay,
And
done.
this lady is from upper socioeconomic status. And germline and our BRCA testing is also awaited. If BRCA comes positive, definitely I would like to change the plan also later.
Definitely HRD and BRCA1, BRCA2 will change the plan of management.
Yes.
Next slide. That is done. Next.
Yeah, genetic testing for most of patients, prevalence of germline testing, multicenter.
So this was a study how much the prevalence of like BRCA1, BRCA2 around 30%. So she underwent neoadjuvant chemotherapy with 3 cycles of paclitaxel and carboplatin. Next slide, please. And she had a good response, partial response to the treatment. Next slide, please. Next. And she underwent interval debulking surgery, and it was like R0 resection. Next slide, please. So, any role of HIPEC at this time during surgery in this patient? Dr. Navdeep?
Hello, am I audible?
Yes, Dr.
Hello.
Navdeep, you are audible.
So yes, hyper can be done in this patient, but normally we are not doing it. So we'll continue with the chemotherapy only.
So yeah, HIPEC data is good in stage 3 ovarian cancers. I square, they have shown around 12-month overall survival benefit. Next slide, please. Next slide. Next. Also benefit, yeah. Next, please. So what adjuvant treatment will Dr. Priyanshu?
Sir, in my practice, in stage 4 and stage 3 with at least moderate to gross ascites, I'm using bevacizumab with germline testing, and if affordable, and it comes out to be either germline BRCA or even HRD positivity, I can add olaparib to that. Bevacizumab I'm not using in NACT. I'm using it from cycle 5 onwards actually.
Okay,
So I'll
you're
like
limiting
to
one
give
cycle
3.
post-surgery.
Yeah. So I'll and by the time I have the results for germline testing also. So I would like to give 3 more cycles of paclitaxel and carboplatin along with bevacizumab from 5th cycle, and wait for the germline testing results and then counsel accordingly.
So yeah, PARP inhibitors have shown a good benefit, and mostly with PAOLA1, the survival is definitely with the HRD positive or BRCA1 mutated. And
Yes.
provided if she comes HRD negative, germline BRCA1, BRCA2 negative, and we got HRD that is also negative. So would you like to add PARP inhibitor?
Sir, Athena Mono 1 is not
HRD
yet
negative.
approved.
Post-surgery R0 resection.
So we don't have the approval.
OS is not like, but
Yes,
PAOLA1
yes, it's
overall
not yet
survival is
approved.
there.
With bevacizumab, so I mean,
So if we look into
although
PAOLA1, 5-year.
yeah, but the magnitude of benefit is not that high, sir. The R ratios are not very, I would
Yeah,
say,
definitely.
impressive.
And even in PAOLA1, 5-year OS was detrimental with the addition of olaparib in this subset.
Yes, sir.
HRD negative. Next slide. So for how long you will continue olaparib? For this lady, R0 resection, germline BRCA positive, 6-cycle paclitaxel done. Bev completed for a year, and olaparib, how long will continue?
Up to 2 years, or till the time she tolerates well, I would like to continue if there's no, physical or financial toxicity.
Definitely, if there is no evidence of disease, no
Yeah.
toxicity, tolerability is not an issue. 2 years definitely. Next, please. Next. So she completed 2 years of olaparib and 18 months. That means 2-year completion. Then 18 months down the line, she developed a pelvic recurrence, CA125 of 120. Dr. Kiran, what will be your further plan for her?
So, as does she symptomatic? If she's a symptomatic, then definitely I
No.
would like to offer. She's a symptomatic and just only showing imaging progression. Definitely, I would wait for a few more weeks. After that, we'll again do the scan and let's see.
Sir, may I?
Yeah, symptomatic if symptomatic and the bulk of disease, then definitely, and she's having she has developed the urinary frequency, and that is a
Okay,
symptom in
okay.
her.
Definitely, if she has a symptomatic and she was recurrence after the 2 years of olaparib and after completing of the chemotherapy. Definitely, she's platinum sensitive. So I would like to go ahead with the chemotherapy. Particularly, I would like to add gem plus cisplatin or gem carbo plus
Why not
bevacizumab also.
lipodox carbo? The data is good with
Yes,
that.
yes. Because the gem is very well tolerated as compared to the lipodox. Lipodox is a 3 weekly, 4 weekly schedule. Tolerance is very poor. In my practice, I have seen the tolerance to lipodox is very poor.
Nudeep, what is your opinion about tolerance
So I also personally prefer.
Gemcis versus lipodox carbo?
So I even personally prefer gemcitabine in along with platinum. If it is a platinum sensitive disease, less comfortable with docetaxel again with the neutropenia and all these cytopenias it causes. So my personal preference would be gemcitabine.
Yeah. So why not
Next,
evaluate
please.
for secondary cytoreductive surgery in this case? I mean, if it's an isolated pelvic relapse, we can do that too.
Hello. Yeah, Dr. Priyanshu, what you said?
I was just coming to this, sir. Why not evaluate if an isolated pelvic relapse with a platinum sensitive relapse, disease-free interval long? So we might try for a secondary cytoreductive surgery. I mean, there are
So yeah,
conflicting
secondary
data.
cytoreduction surgery can be done, but the data is not post olaparib. It's
Yeah,
not
definitely.
post parab. So yeah, definitely we can try because the biology of disease is good. She has been like 2 years, olaparib completed 1.5 year
3.5
disease-free interval. It can be tried, but data is not here. We can try, but yeah, data is not here. So whatever the secondary cytoreduction they have done, it was upfront. Then they followed with the chemo. So secondary cytoreduction, one trial is positive, one is negative, and one is still in the way. And with the addition of, I think, Bev, then PARP inhibitor, we never know benefit or not. Let the third trial also come. Then it can answer whether it will benefit or not. Next slide, please. So yeah, these are the 3 trials of secondary cytoreduction: Desktop 3, GOG213, and SOC1. SOC1, this overall survival data is not mature. And if we see the PFS advantage is still definitely there in both, in all the trial PFS advantage is there, but overall survival, Desktop 3 is positive and GOG213 was negative. The only issue was patient criteria. Bevacizumab used mostly in GOG213, but it was not used much in this Desktop 3. Next, please. So yeah, this is the 3 trials in a nutshell. The patient selection criteria was different, and what was the major difference in GOG213 and Desktop was there was a criteria built up for patient selection in both this SOC1 and Desktop trial. But in GOG213, it was mainly up to the surgical domain whether we can cytoreduce it completely or not. There was which was built to decide the optimal cytoreduction, secondary cytoreduction. So that may be the reason GOG213 may be negative. But let's see what SOC1 tells us when the overall
Sir,
survival
kindly
also
conclude
matures.
your talk in 2 minutes, please.
Next, please. Yeah, please, next. Next slide, next. So she underwent secondary cytoreduction. What will you proceed with the adjuvant treatment, Dr. Navdeep? She received 3 cycles gemcitabine, not chemo. So she underwent secondary cytoreduction upfront. It is surgery.
After secondary cytoreduction, and yes, I would like to continue with the chemo, sir.
How will you proceed with the adjuvant treatment?
Hello.
So 6 cycles chemotherapy. Any role of bevacizumab in such a case? Secondary cytoreductive surgery. Then have anyone used bevacizumab post cytoreduction, secondary cytoreduction?
No, I have not used post. I have not personally not used.
Dr. Priyanshu?
Not, sir. No, I'm not used post secondary cytoreduction.
Is also not there, definitely. And whatever trials they have done with this chemos. And any role of re-challenge of PARP inhibitor? That we can reach.
Gurvinder sir, your voice is so breaking.
Any role of PARP inhibitor re-challenge in this case? Manu, next slide. So this is a trial that have shown that there can be a benefit in re-challenging in a platinum sensitive PARP inhibitor again who have received. Next slide, please. And the benefit was
kindly conclude.
And this benefit was mainly in BRCA negative subgroup, though statistically significant in both BRCA positive or negative. Next slide. Next slide. Yeah, thank you. So thank you, Dr. Kiran, Dr. Priyanshu, and Dr. Navdeep.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, Dr. Gurvinder. Thank you, Dr. Priyanshu, Dr. Kiran. For the next section, next and the last session of this webinar, I would like to invite Dr. Sushant Mittal. Sir is a medical oncologist at Max New Delhi. Sir will be taking the topic of triple negative breast cancer and particularly the role of metronomic therapy with cyclophosphamide and capecitabine in this setting.
Thank you, Dr. Piyush, for giving me this opportunity. I'll switch off my camera because my battery is very low. So I'll just talk without the camera on. Can you please, organizers, please show my slide set?
Hearing, sir.
Yes. So triple negative breast cancer is a very heterogeneous disease that few patients relapse very soon, few patients relapse later on. And since we don't have any targetable mutation with us, except for BRCA in few patients, we are most of the time after giving chemotherapy, probably anthracycline, taxane, gemcitabine, we don't have much of the options available with us. Even after doing an NGS, we sometimes don't get adequate answer how the patient needs to be treated. And many a times patients are in good performance status, or patient has run out of finances, or patient doesn't want intravenous chemotherapy, they are sick and tired. So in those settings, we use, and I have also used metronomic therapy, especially in various combination of endoxan or methotrexate or capecitabine, celecoxib. All these drugs in various combinations we have used. However, till now, we didn't have any fixed drug combination such as capecitabine and cyclophosphamide in breast cancer. Next slide, please. So the rationale of next slide, please. The rationale of combination of capecitabine with next slide with cyclophosphamide is that next slide. Both are antimetabolite. Capecitabine has high single agent activity, which has a unique safety profile with no alopecia and low incidence of myelosuppressions. And the data on the efficacy of using combination of capecitabine is there, but in phase 2 trials, we don't have any phase 3 trial data for this. Next slide. Excuse me. So the rationale for combination is that when capecitabine goes into the, we know it's a pro-drug, when it goes into tumor cells, it gets converted into thymidine phosphorylase, helps to convert into 5-FU. Next slide. And this endoxan enhances, next slide please. This endoxan or cyclophosphamide enhances the activity of
Please, next slide. Abhimanyu? Yeah.
Yes. So it enhances the upregulation of thymidine phosphokinase and helps increasing the intertumoral drug quantity of 5-FU. Hence, they have a synergistic effect. The rationale of combining the two drugs is always that cancer has multifactorial pathways, and that's why we need drugs which act directly on the cancer cells. They have anti-angiogenic effect, immune mediated effect, and to some extent an endocrine effect. So the combination of these two drugs takes care of these 4 pathways in different ways so that we achieve an anti-mitotic activity. Next slide. We have this phase 2 data which was published in the Oncologist SWOT 2012. Next slide, which showed that the combination of these two drugs have a favorable outcome, but they were both used in individual capacity, not as a pill in a pill format. Next slide. Next slide. So flat dosing concept was derived from this phase 2 data. Next slide. But the question was, in metronomic setting, which other drugs can be combined? As I told you previously, these drugs we commonly use. However, the combination of capecitabine with cyclophosphamide has been till now proven to be benefit after the launch of Comcapsi, and I have used in I think more than 50-55 patients as a metronomic therapy. Next slide. I'll share my personal experience in a while. So this is another Penolop project which again showed that the use of metronomic chemotherapy in advanced breast cancer is useful. Next slide. Next slide. So metronomic therapy as defined previous slide is frequent low dose therapy on a regular interval without much side effect, and it gives a good toxicity profile. However, till now we don't have any phase 3 data for these two combination. Next slide. Next slide. These all articles tell us that metronomic therapy is important. We are well aware of that. We have this Indian experience also. Next slide. So this is the data, what I'm talking about. Since there was an unmet need of a phase 3 trial, of lack of any pharmacokinetic data. So this is a prospective, adaptive, randomized, open-label, multi-centered clinical trial to study the efficacy and safety of a fixed dose combination of capecitabine and cyclophosphamide in patients with metastatic breast cancer who have failed with anthracyclines and or taxanes chemotherapy. Next slide. So we had these 3 combinations in which it was 1400 of capecitabine plus 60 mg of cyclophosphamide, 1800 of capecitabine with 60 mg of cyclophosphamide, and 2200 of capecitabine with 100 mg of cyclophosphamide. This was the total dose, which was divided into morning and evening, as has been shown in group 1, 2, and 3. However, the group 1, next slide, group 1 pharmacokinetics was not very significant, hence it was not studied. And the data what I'll be telling you is just for group 2 and group 3. Next slide. So DCGI permission was taken and metastatic breast cancer TNBC were included without brain mets patient or treated brain mets. Next slide. The primary endpoint was overall response, which included CR and PR. And the secondary endpoint was disease control rate, which included CR, PR along with stable disease. Why? Because stable disease is also a response in a metastatic setting when we are looking at a palliative intent. And of course, the safety profile. Next slide. Next slide. So baseline characteristics were well balanced between the two arms. The median age was around 50 years with BSA of 1.50, which in our clinical practice also, most of the patients do have this body surface area, and majority of the patient had good performance status of ECOG 1. Next slide. The intention to treat population, if we see that the disease control rate, which included CR, PR, and stable disease, 87% of the patients we were able to achieve a disease control rate, which was the secondary endpoint. Next slide. And the response rate, if we see again that CR and PR was also significant in this population. However, in my own experience, I would say that stable disease and PR is the most common response what I have seen. CR I have seen, but I would say in about 10% of the population I have seen CR. And next slide. I have used this combination not only in metastatic breast cancer, but as well in oral head and neck cancer, squamous cell carcinoma, when patients do not want further chemotherapy or they are in poor performance status. I've used in vulval cancers, penile cancers. In them also, in elderly population, penile cancer patients who do not want to undergo extensive surgery or penectomy along with lymph node dissection, they are not willing in elderly population, or maybe sometimes in younger population as well. I've used this combination and have patients are doing well till about, I have the data for about almost 18 to 19 months of therapy of a penile cancer patient who has done very well. Also, the vulval cancer patients who have extensive disease, it becomes difficult for them. That fungating mass is not responding to anything, to paclitaxel, bevacizumab, carbo, gemcitabine, irinotecan, and we have tried. It is not responding. In one of my patients of lymphoma as well, I have used this combination they were from EWS category, and after CHOP and GDP, the performance status wasn't good, and they were not affording for rituximab. So I had to start them on this oral Comcap-C, and to my surprise, that they responded to this combination, and she lived on for almost 1.5 years without any disease, and later on succumbed to a pneumonia. So next slide. So my experience with this drug has been very good, in the sense that the side effect profile is good. The patient doesn't have much of the myelosuppressions. The nausea, vomiting is easily controlled with pantoprazole and ondansetron. No higher end antiemetics are required. Next slide. The most important, the published historical data, if we see that in our study, the disease control rate has been to the tune of 87 to 84, which is much higher compared to the historical data of to the tune of 57 to 68%, and the overall response rates have been to the tune of 30%. Next slide. The advantage of this is that,
Sir, kindly conclude your talk in 2 minutes, please.
yes, the advantage is that the pill-in-pill tablet is a patent which has been awarded to this company, and the compliance with the drug is very good because the pill burden is reduced significantly. Next slide. Next slide. Next slide. Next. Please come to the summary slide. Next slide. Next. Yes. So to conclude, there is a synergistic anti-tumor activity. There's an established efficacy with this data. We have achieved a balance between the side effect profile and the response rate. And it's an oral alternative with pill-in-pill tablet, which gives us a good compliance. Thank you so much for your patient hearing. Back to the organizers.
Thank you, sir. Thank you for this extensive talk, sir. Definitely, I will use it in more patients because I haven't used it in much of my patients. But definitely, as you have used and you have a very extensive data regarding this drug, so definitely that I think that it can be used in other malignancies, like as you have mentioned also in other squamous cell malignancies.
Yes. Thank you. Thank you so much.
Okay. Okay, sir. Over to organizers, over to Horizon.
Thank you, sir. Thank you, Dr. Piyush Mehta, and all the doctors who have joined today for the 2 days academic feast. Thanks to our academic partners who have supported. And till then, we'll meet. Good night, everyone.
Good night. Thank you.
Good
Thank
night.
you.
Thank you, sir. Thank you so much.
We'll meet tomorrow, most likely.
Yes.
Okay. Good night.